The Senate Committee on Health, Education, Labor, and Pensions will please come to order. This morning we're holding our first hearing on stabilizing premiums and ensuring access to insurance in the individual health insurance market for 2018. We have 5 state insurance commissioners. Thank you for coming from long distances, some of you, to be with us to give your testimony on how to help the 18 million Americans in the individual insurance market. To give an idea of how many people are interested in this, Senator Murray and I invited senators who were not on our committee, which has about a quarter of the Senate is on this committee, to come to a coffee with the 5 commissioners that we've just completed for an hour. We had 31 senators there. So that's a remarkable level of interest. Senator Murray and I will each have an opening statement, then we'll introduce our 5 witnesses. After their testimony, senators will have an opportunity to ask witnesses questions, and we'll do it in 5-minute rounds. So I mentioned this committee includes 23 United States senators, nearly 1/4 of the members of the Senate. It includes senators with the widest divergence of views. It has a Republican majority of only 1. Yet working together during the last 2 years, we've been able to agree on big steps, on big issues about which we have big differences of opinion, such as fixing No Child Left Behind, which President Obama called a Christmas miracle, 21st Century Cures, which Senator McConnell, the majority leader, says was the most important piece of legislation that passed Congress last year, the first overhaul of mental health laws in a decade. And in early August, after 2 years of work, and I want to thank the staff for that 2 years of work, especially, we passed new agreements to help speed safe drugs and devices into medicine cabinets and provide $9 billion in funding for the Food and Drug Administration. I congratulate Senator Murray and Democratic as well as Republican members of the committee for those accomplishments. This is the way Americans expect the United States Senate to work. Now, those were big steps. This hearing is about taking one small step, a small step on a big issue which has been locked in partisan stalemate for 7 years, health insurance. It is a step Congress needs to take by the end of this month. By the end of this month. The step's not so big to 18 million Americans, songwriters, the self-employed farmers, those who don't get their health insurance from the government or on the job. These 18 million buy their health insurance in the individual market, and about half of them have zero government support to help buy that insurance. 18 million is only 6% of those who have health insurance in America. So that's the individual market. Nearly 300 million Americans have insurance, health insurance. 18 million buy it in the individual market. That's 6% of all the insured, and 9 million of those 18 million have no government help to buy their insurance. They're the ones most hurt by higher premiums and higher copays and deductibles. Let's take a hypothetical Tennessean. A 35-year-old making $48,000 a year in Lynchburg would receive no tax benefit to cover her $7,100 per year premiums. She's an estimated take-home pay of $39,000 after taxes, which means almost a fifth of her take-home pay is spent on health insurance premiums, and this doesn't include deductibles or copays. Next year, the Tennessee Department of Insurance says premiums are going to go up by an average of 21 to 42%. That's an increase for her of between $1,500 and $3,000 more in premiums next year, and that doesn't include increases in deductibles and copays. She ought not to have to pay a fifth of her income for health insurance. Tennessee's insurance commissioner, who's here today, has described the state's individual market as very near collapse. At the end of September last year, Blue Cross, our largest insurer, pulled out of the individual market in Knoxville, Nashville, and Memphis, not just for Tennesseans with Affordable Care Act subsidies, but for everybody. That could happen again at the end of this September if Congress doesn't act. And if it happens again, up to 350,000 Tennesseans and millions of Americans could literally be left with zero options to buy insurance in the individual market. Last year, Only 4% of American counties had one insurance commissioner on the exchange. This year, 36% have one insurer on the exchange. And for 2018, one half of the counties will have one insurer only on the exchange. In Tennessee, it's 78 of our 95 counties. If we do act, we can limit increases in premiums next year, 2018. We can continue support for copays and deductibles for many low-income families. We can make certain that health insurance is available in every county and lay the groundwork for future premium decreases. I would suggest we do this by taking two actions, although there may be others that come from these hearings. One, appropriate cost-sharing payments through the end of 2018 to help with copays and deductibles for many low-income Americans. Two, amend the Section 1332 waiver already in the Affordable Care Act so states can have more flexibility to devise ways to provide coverage with more choices and lower costs. On the first, cost-sharing payments are extra subsidies or discounts, really, for many low-income individuals who receive premium subsidies under the law. They help these individuals pay for out-of-pocket costs like copays and deductibles, but their overall effect is to lower premiums in this individual market. On the second, the Section 1332 waivers, as I said, are already written into the Affordable Care Act. Under some circumstances, they allow a state flexibility from certain elements of the law, such as essential health benefits, but they do not in any way reduce the patient protections most of us support, including protections for those with pre-existing conditions and ensuring those under 26 may remain on their parents' insurance and have no annual or lifetime limits. Right now, 23 states have begun steps to apply for a Section 1332 waiver. 7 states have applied. 2 states, Alaska and Hawaii, have received the 1332 waivers so far. Now, to get a result, Democrats will have to agree to something, more flexibility for states that some may be reluctant to support. And Republicans will have to agree to something, additional funding through the Affordable Care Act, that some may be reluctant to support. That is called a compromise. A much smaller but similar agreement to the compromise that created this United States Senate in 1789. When the founders created a Senate with 2 members from each state and a House of Representatives based on population, that was a compromise. This is a compromise that we ought to be able to accept. Temporary cost-sharing payments were included in both the Senate and the House Republican bills to repeal and replace major parts of the Affordable Care Act. The Section 1332 waiver is already in the Affordable Care Act. It just hasn't been very appealing to states because it's a difficult tool to use. We hope to hear more about that from our witnesses today. If we were able to take the big steps I mentioned earlier, fixing No Child Left Behind, passing 21st Century Cures, we ought to be able to take this small, limited, bipartisan step on health insurance. If we don't, millions of Americans will be hurt. Timing is a challenge, so I propose that we try to come to a consensus by the end of next week when our hearings are complete so that Congress can act on what we recommend before the end of September. Otherwise, we won't be able to affect insurance rates and the availability for insurance next year. That's because the Department of Health and Human Services requires insurance companies to submit their final rates by September 20, and the department plans to put those rates on healthcare.gov by September 27. I believe we can do it here because we're plowing very familiar ground. Our goal is a small step, and so many Americans will be hurt if we fail. If we don't do it, it won't be possible for Republicans to make political hay blaming Democrats or Democrats to make political hay blaming Republicans. The blame will be on every one of us, and deservedly so. So now let me conclude with a word about process. We'll have 4 hearings. We're hearing from state insurance commissioners today. We're hearing from 5 state governors tomorrow. We'll hear from various experts on state flexibility next Tuesday and a variety of helpful perspectives next Thursday. including representatives from doctors, hospitals, insurers, patients, and insurance commissioners. This is what we call a bipartisan hearing. Most of our hearings are. That means that Senator Murray and I have agreed on the hearings, on its topic, and on who the witnesses will be. This committee has a clear jurisdiction over the rules that govern the individual insurance market, which is what we're discussing today. We have jurisdiction over private insurance, over the exchanges created by the Affordable Care Act, and over the cost-sharing reduction payments. The purpose of the hearings is to provide a forum and create an environment for reaching a consensus that we can act on quickly during the month of September. Now, note that we do not have jurisdiction over taxes, including the Affordable Care Act tax credit subsidy, nor over Medicare, nor over Medicaid. Those belong to the Finance Committee, although there are at least 9 members of that committee on this committee. There's been such great interest in this effort that senators who are not members of our committee are being invited to coffee before each of the 4 hearings. As I said, 31 senators came to the one today. Senator Murray and I have invited them to do that and to participate in this process. My goal is to get a result on a small, bipartisan, and balanced stabilization bill. Where it makes sense, we'll work with other committees and members to get that result. Health insurance has been a very partisan topic for a very long time. But the bottom line is 18 million Americans need our help. I hope we can stay focused on getting a result. Senator Murray.
Well, thank you very much, Chairman Alexander. And I do want to start by expressing my appreciation for your leadership in holding these hearings. It is refreshing to have an opportunity for frank and bipartisan discussions on the healthcare system, and consistent, as you said, with longstanding tradition of working across the aisle on this committee. So thank you very much. I'm also very grateful to each of the insurance commissioners who've come a long way to join us today. Your perspective is incredibly valuable in this discussion. I'm looking forward to hearing from each of you. And I particularly want to acknowledge Commissioner Mike Kreidler, who came all the way from Washington State today. Good to have you here as well. We're beginning these conversations at an important moment for patients and families. There's a lot of work that needs to be done to undo the damage this administration has caused within the healthcare system, because this administration is still trying to create Trump care by sabotage. Our healthcare system is more stable than President Trump's tweets would have you believe, but it is weaker as a direct result of some steps that have been taken. Unfortunately, the President has undermined outreach and consumer assistance efforts and put forward executive orders seemingly designed to inject uncertainty into the markets. Just last week, this administration cut funding for outreach by 90% and funding for consumer assistance by over 40%. And another pressing example is the threats to cut off payments to reduce coverage costs for low-income people. Should these out-of-pocket cost reductions be discontinued, independent analysis suggests that premiums could be an average of 20% higher next year for the most popular plans on the exchanges. There will be even more uncertainty in the markets, and patients and families likely will have fewer options when they go to pick their plans. That is unacceptable, and it is avoidable. Congress can act right away to confirm once and for all that out-of-pocket reductions will continue, and we will have a very narrow window to do that, as the chairman said, before insurances finalize their plans for 2018 later this month. I am very glad that there are members on both sides of the aisle who agree that we do need to take this step, and I believe it is critical we work towards a multi-year solution in order to provide the kind of certainty that will have the most impact on families' premiums and choices in the marketplace. It takes plans months to develop their rates. If we don't find a multi-year solution, we're just going to be back in this room trying to patch the same problem a few months from now. And that's simply not what certainty looks like. This kind of discussion around strengthening our healthcare system is exactly what Democrats have hoped for over the last few years. We put forward a number of ideas that would help stabilize markets and lower costs in the near term. And as I said before, as we work together, I'm more than ready to consider additional ideas from the other side of the aisle to make our healthcare system work better for our families and for patients. But to be clear, that means moving forward not backward, on affordability, on coverage, and quality of care. Families have rejected the damaging approach taken in Trump Care, which would have raised families' costs and gutted critical protections like those for pre-existing conditions, and Congress should listen. I think we're all aware threading this needle will not be easy, but I do believe in agreement that protects patients and families from higher costs and uncertainty and maintains the guardrails in our current healthcare system is possible. This kind of agreement would not only make a real difference for the patients and families that we serve, but it could provide a bipartisan foundation for future work. I've said many times before, this work didn't end when the Affordable Care Act passed. It's certainly true today. There's much more we need to do to strengthen the healthcare system, to lower costs, to expand coverage, and improve quality of care. And these are the issues we should be able to work together on in a bipartisan way. I hope with today's conversation we continue to turn the page away from Trump care and partisanship that we've seen way too much of, and instead start working on healthcare policies to help our patients and families afford the care that they need, because that is the goal that we should all be focused on. I'm so glad we've seen interest on both sides of the aisle for coming together and working to find common ground on these issues. And I want to again thank all of the commissioners and all of our colleagues who are joining us today, and turn it back over again to Chairman Alexander.
Thank you, Senator Murray. Our first witness is Julie McPeak. She's Commissioner of Tennessee's Department of Commerce and President-elect of the National Association of Insurance Commissioners. She's testified here before. Welcome, Commissioner McPeak. Our second witness is Mike Kreidler. Senator Murray has already welcomed him and acknowledged him. He's Washington's 8th insurance commissioner, the state of Washington, and the country's longest-serving commissioner. I'll ask Senator Murkowski to introduce the next witness.
Thank you, Mr. Chairman. It is a pleasure to introduce to the committee an individual who has been before us before. Director Lori Wing-Heier is Alaska's Director of Insurance. She has been in that position since 2014 and has done an exceptional job. We recognize not only her service there, but she is also the chair of the American Indian Alaska Native Liaison Committee on the Association of Insurance Commissioners. She is, as you have noted, one of two, or Alaska is one of two states that has received a 1332 waiver, and it has been under the guidance of Director Wing-Heier that we have seen that come about. So I thank her not only for being here today, but for her leadership and her persistence in working not only with the Obama administration, but with the Trump administration in getting that final sign-off.
Thank you, Senator Murkowski. Senator Casey, would you like to introduce the next witness?
Yes, thank you, Mr. Chairman. I'm pleased to introduce Teresa Miller, who's Pennsylvania's acting Secretary of Human Services and former Pennsylvania Insurance Commissioner. Secretary Miller served as Insurance Commissioner from 2015 through August of this year, when she was nominated by Governor Wolf to serve as Secretary of Human Services. In her role as Insurance Commissioner, she's been a vocal supporter of Pennsylvania's health insurance marketplace, demonstrating a deep understanding of the insurance industry while advocating for policies in the best interests of Pennsylvanians. I congratulate her on being nominated to serve as Secretary of Human Services and happy to welcome her to the Help Committee today. Secretary Miller, thank you for your testimony today. We're grateful you're here.
Thanks, Senator Casey. Our fifth witness is John Doak. We welcome you back, Mr. Doak. You were here before to help us understand the issues. He's Commissioner for Oklahoma's Department of Insurance. He's well known for hosting healthcare innovation summits within his state, which seek to offer cutting-edge solutions to the country's healthcare challenges. Well, as you already know from the meeting we've had earlier, there's a lot of interest here among senators. So if you could please summarize your remarks in about 5 minutes, we'll then turn to a series of questions from senators. To follow that up, let's begin with you, Ms. McPeak.
Thank you. Good morning, Chairman Alexander, Ranking Member Murray, and members of the committee. I am Julie McPeak, Commissioner of the Tennessee Department of Commerce and Insurance. Today, I plan to highlight Tennessee's history with the ACA and discuss some immediate solutions that Congress can consider to stabilize the individual insurance market. Before I get started, I would like to thank you for holding today's hearing and for inviting so many of my state regulator colleagues. In an interview last year, I characterized Tennessee's individual health insurance market as very near collapse. In the 12 months since, thankfully, our market has not collapsed, but our market is not any more stable and probably less so. Tennessee in 2017 has continued to see health insurance carriers flee the market due to the tremendous uncertainties surrounding the 2018 plan year, as well as year-over-year of substantial losses. As of today, and subject to change until QHP agreements are signed later this month, Tennessee consumers across the state will have at least one option for coverage, but only one in the clear majority of our state. While we feel very fortunate that Tennesseans will have an opportunity for coverage, I don't think that many people believe that having a single choice in 78 of 95 counties represents ideal market competition. To summarize Tennessee's experience over the last 4 years, our consumers have seen premium prices skyrocket while their plan choices have diminished. Tennessee had around a dozen carriers offering individual health insurance coverage in 2010, reduced to only 3 companies offering ACA-compliant plans in 2018. Tennessee's current ACA trajectory, quite simply, is not sustainable. Today's hearing couldn't be timelier as we are approaching a September 20th deadline for final determinations on 2018 rate filings. Tennessee's carriers filed rates assuming the CSRs are not funded, with each carrier attributing approximately 14% of their average rate increase to CSR uncertainty. According to CMS data, approximately 120,000 Tennesseans are enrolled in CSR plans, representing almost 60% of our FFM market. The CSR funding issue is the single most critical issue you can address to help stabilize insurance markets in 2018. And to be clear, this issue is not an insurer bailout. CSR funding ensures that some of our most vulnerable consumers receive assistance for copays and deductibles that are required to be paid under federal law and has the effect of reducing proposed premium increases and has a direct impact on the amount of subsidy assistance provided by the federal government. In fact, as you know, last month the CBO reported that federal deficits would increase by $6 billion in 2018 if CSR funding is terminated. But on the other hand, should the federal government agree to fund CSRs and CMS works with the states, Tennessee, we could see proposed increases for 2018 be reduced. Beyond CSRs, Congress should also establish a reinsurance mechanism that would stop losses for individual claims at a specified amount to increase market participation by carriers. For the most immediate impact, this backstop mechanism must be federal, as it would be impossible for many states to develop such a program for the 2018 plan year. States should have the option and flexibility to set up their own programs to reflect our unique dynamics and market conditions, but the federal government should set up a default mechanism to stabilize markets during any transition to a state-run program. Following these immediate measures, CSR funding and reinsurance, Congress must address broader ACA reforms, such as benefit design, rating restrictions, and the underlying cost of health care. As the cost of health care services increase, so too must the cost of health insurance. This causal relationship is simple to understand, yet is too often not discussed in conversations of health insurance reform. Health insurance rate requests are subject to review by state insurance departments and in FFM states, the federal government. In Tennessee, the rate review process is an entirely public one. As soon as a rate is filed, it is publicly accessible to anyone interested. Rates are filed and approved on a plan year basis that prohibits rate changes during the year and provides consumers notice before a rate increase for the following year. These parallel protections are non-existent in the pharmaceutical industry, and this level of transparency is lacking in determining appropriate costs for medical services. These issues cannot remain to be unaddressed in our focus on health insurance rates and accessibility. In conclusion, consumers around this country need and deserve access to quality health insurance coverage at affordable rates. Working together, we can get back to a place of vibrant, competitive markets where insurers look to expand rather than contract their operations. Congress should focus on 2 critical elements to make that possible: CSRs and reinsurance. After addressing these issues, Congress should focus its attention on broader conversation of our nation's health and strategies to improve health outcomes while reconsidering tenets of the ACA that have led to challenged and potentially unsustainable markets across much of the country. Thank you again for your time. I look forward to answering your questions.
Thank you, Ms. McPeak. Mr. Kreidler.
Good morning, Mr. Chairman and Ranking Member Murray, and members of the committee. My name is Mike Kreidler, and I'm the Insurance Commissioner for the state of Washington. I want to thank you for your bipartisan commitment to address the challenges that we as insurance commissioners are facing, but also you are facing in the coming months. This is especially true for the individuals and families who buy their own health insurance, some 330,000 people in the state of Washington. They really are the health of that market is really the canary in the coal mine. If there's a problem in the individual market, it is a problem for all of us. This is made up, as you pointed out, Chairman Alexander, is that early retirees, self-employed, people who work for employers who don't offer health insurance. The individual market is clearly a very critical safety net. Where we rely, they are relying on us to find a path forward that offers a great deal more certainty than what we have right now. Washington State has fully embraced the Affordable Care Act from the very beginning. We have a very stable market since 2014. Our uninsured rate has plummeted from 15% down to under 6% in the state of Washington. But this year, there's been a serious jolt to the system. Initially, we had two counties in the state of Washington that didn't have any health insurers. We solved that problem, thankfully. But I'm nervous about what's going to happen next year. Because of the growing uncertainty and actions by the administration, our individual health insurance markets are in serious peril. The proposed average rate increases that we've seen for 2018 are 23%. In years past, it's been under 10%. 9 rural counties have only one insurer. One major insurer largely pulled back in our state completely from western Washington, where most of the people live. The next 2 weeks are going to be very telling. Insurers will be making their final decisions as to whether they're going to participate in the health insurance marketplace or not. Congress must act quickly to address these growing uncertainties. You must permanently fund the cost-sharing reduction payments. That's something that's going to help a great deal in our marketplace. It affects some 72,000 people in the state of Washington. For a low-income family in the state of Washington, the deductible is the difference of being $1,200 with the CSRs or $14,000. I urge you to create a federal reinsurance program this year. Doing this would show your commitment to stabilizing the market. It worked very well in the state of Washington for the first 3 years that we had a reinsurance program. We'd like to see it continue and go forward. It's another way of reassuring the insurance market that the insurance carriers, it doesn't help them financially, but it gives them predictability and helps us hold down the rates. Make sure that you maintain the coverage and affordability guardrails in the 1332 waivers. Willing to play by the rules. What we don't want to see is that the essential health benefits, the guarantees on out-of-pocket costs are eroded away. Those are consumer protections that nobody wants to see leave the marketplace. In closing, let me say that you must take bold action now to shore up these markets. So millions of hardworking families and individuals are counting on us. In Washington State, we have firsthand experience with what can happen if violating and basic insurance principles are allowed to occur, and they are occurring right now. And this, we tried this in the 1990s, and we saw the individual market in the state of Washington totally collapse. Believe me, that's something no one wants to go through. Let me be a harbinger here and say this: it can and will happen if you do not take action now. That's how critical it is out there in that insurance market to make sure we don't have that kind of collapse we saw in Washington happen for the whole country in the individual market. Lives depend on it. Our lives rest on your bipartisan efforts. Thank you, Mr. Chairman.
Thank you, Mr. Kreidler. Ms. Wing-Heier.
Thank you for the opportunity to testify today about the health insurance market in Alaska and the need for congressional action to help people in the individual insurance market in 2018 and beyond. Alaska has amongst the highest cost of health care in the nation due to low population density and limited health care provider or facility competition in much of the state. While the individual mandate reduced the number of uninsured Alaskans, an unintended consequence was that the high cost of the individual health insurance premiums increased even further. Premiums in the individual market in Alaska have increased by 203% since 2013. On average, an Alaskan in 2013 was paying a monthly premium of $344 per month, and in 2017, that premium is $1,041 per month. To stabilize this volatile market, the Division of Insurance worked with Governor Bill Walker to create the Alaska Reinsurance Program. The 29th Alaska State Legislature passed the governor's bill in 2016 with overwhelming bipartisan support. The Alaska Reinsurance Program is intended to provide stability to the individual health insurance market, mitigating rate increases by removing high-cost claims. As planned, this had an immediate impact on rates. Prior to enacting the reinsurance program, indications were that the rate filing from the single insurer in Alaska would be close to 40% in 2017. After enactment, the rate increase was a moderate 7.3%. An independent actuarial analysis estimates the reinsurance program will increase enrollment in the individual market by 1,650 individuals. Modeling also indicates that the program may attract healthier members to the individual market, further reducing premiums. After enacting the reinsurance program, Alaska then applied and was subsequently approved for a federal ACA Section 1332 state innovation waiver. Alaska waived the requirement of a single risk per pool and proposed that the federal government provide pass-through funding for a period of 5 years to secure the state's reinsurance program. The pass-through funding is based on the savings generated as a reduction in the advanced premium tax credits. It is estimated that the Alaska Reinsurance Program will save the federal government $51.6 million in advanced premium tax credits in 2018 relative to what would have been the tax liability had the program not been put into place. After the federal pass-through funds are accounted for, the state will be responsible for providing approximately 15% of the $55 million program cost necessary to stabilize the individual market. As you consider congressional action to stabilize premiums across the country in 2018, we offer the following perspectives. We'd urge Congress to not disrupt the health insurance market, but instead focus immediately on stabilization. Any decision made after the filings are approved could cause unintended, unfavorable disruption to insurance markets. Uncertainty destabilizes the market. Committing to funding cost-sharing reduction payments through at least 2019 will keep premium rates from increasing at even higher rate. We support collaborative reforms developed in consultation with state regulators that strengthen markets with the goal of health insurance not only being accessible, but affordable. Programs that allow states to address the unique needs of their citizens, such as the Section 1332 waivers, are vital to the long-term stability of health insurance markets. Further deliberation on health insurance taxes are needed. In particular, citizens of states like Alaska that already face extremely high healthcare costs may be unfairly penalized by the Cadillac tax. Additionally, exempting insurers from health insurance tax in counties or states served by one insurer may be an effective way to increase choice or competition that will benefit citizens, but should be considered for all states as a moratorium. Please consider continuing and funding the Navigator and Assister programs. In rural areas of Alaska, insurance brokers and consultants are hard to find. These programs reduce the number of uninsured citizens and maximize market participation. Media and public announcements are vital to open enrollment being successful. A review of regulations may reveal that some that are unnecessarily burdensome and costly to both medical providers and insurers. We are also interested in coordinated efforts with healthcare providers to address the underlying costs underlying drivers of healthcare spending. Even under the extreme tight considerations you face to address 2018 premiums, please make your decision in a bipartisan manner after thorough analysis. We are here to assist you in any way we can, and I look forward to your questions. Thank you.
Thank you, Ms. Wing-Heier. Ms. Miller, welcome.
Good morning, Chairman Alexander, Ranking Member Murray, and members of the committee. I'm honored to be here today and want to applaud the committee for hosting such an important conversation at such a critical point in time. I'm not going to sit here this morning and tell you that the ACA is perfect. I think we all know that it's not. But the narrative that the ACA is failing and imploding is just false and ignores the coverage requirements that the law put in place. Millions of Americans have benefited from the ACA, and the employer markets where the majority of people get their insurance have actually seen a moderation of costs since passage of the ACA. Pennsylvania's uninsured rate is now the lowest it's ever been, thanks to improvements in the individual market and Governor Wolf's expansion of Medicaid in 2015. Pennsylvania has about 426,000 people on the individual marketplace, and about 80% of these enrollees receive subsidies to help them pay their premiums, and more than half benefit from cost-sharing reductions that help them pay with their out-of-pocket costs, like copays and deductibles. So for most individuals in this market, the ACA is working well. The ACA has resulted in millions of Pennsylvanians no longer being denied coverage due to a pre-existing condition, or facing financially devastating annual or lifetime limits, and benefiting from quality, comprehensive coverage because of preventative care and essential health benefit requirements. Pennsylvania's market has experienced difficulties, but our individual market is not collapsing. Our individual market insurers filed for an average increase of just 8.8% for 2018, assuming no changes to the ACA. I'm pleased to report that our insurers are finally seeing improved experience with this market, and that's reflected in their rate increases. But I'm also very concerned that that stability is on fragile ground because of the ongoing uncertainty surrounding the future of the ACA, and in particular, payments for cost-sharing reductions. I cannot stress enough how difficult this uncertainty is on our markets. These payments have a significant impact on rates, and failing to make a long-term commitment will do nothing but drive up costs for consumers. This will further hurt the 1% to 2% of Pennsylvanians, roughly 125,000 people, who don't receive subsidies, because those who do will be shielded mostly from these premium increases, if their insurer stayed in the market, that is. Ultimately, rates have to be finalized based on finite assumptions. Pennsylvania consumers will be left to bear the burden of premium increases or lessened choices necessitated by continued uncertainty. Congress should allocate money for these payments through at least 2019 to give insurers the predictability they so desperately need. We also must make sure that we're properly encouraging enrollment in the individual market. The health of any insurance market depends on the strength of its risk pool, and reduced enrollment strains the risk pool and contributes to rising costs for all of those in it. I worry steps the Trump administration has taken could further erode the risk pool. Just last week, we found out the extent of cuts to outreach and enrollment efforts funded by the federal government. Health and Human Services will spend just $10 million advertising 2018 open enrollment, compared to the $100 million spent for 2017. In addition to this, funding granted to health insurance navigator organizations to help people enroll was almost halved from the levels given under the previous administration. Reducing outreach efforts at the federal level, combined with a shortened enrollment period for 2018, will do nothing but leave more people without coverage and could raise rates for people left in the market. In Pennsylvania, we're implementing our own outreach program. We're working alongside insurers, healthcare providers, consumer advocates, and other stakeholders to reach our common goal of increasing covered Pennsylvanians. Encouraging enrollment helps everyone. People have access to coverage, insurers have a more robust risk pool, and providers are more likely to receive compensation for care they provide. Over time, a more robust risk pool should also result in lower premiums for consumers. As we work towards providing stability in the market, we should consider all options to moderate the premium increases caused by market instability. A $15 billion reinsurance program in the context of a careful bipartisan approach to improving our healthcare system would be a great place to start, especially if the individual mandate were preserved and outreach was boosted to increase enrollment. The ACA's reinsurance program successfully moderated premiums while it was in place, and a reintroduction of a long-term reinsurance program could be an effective way to scale back the premium increases that we currently see. Finally, I do think we need to have a serious national conversation about healthcare costs in this country. These costs are constantly growing, and even if we bring stability to our markets, we must still address healthcare costs if we want to ensure that our current system is sustainable in the long term. This is a national issue, and even as states work to address rising costs in our own markets, we're not going to be able to fix this completely on our own. While the healthcare reform debate has been without question partisan, the goals that we're trying to achieve are not, and neither is recognizing the real problems that exist in our system. We all want Americans to have access to the care they need and be able to afford that care, and we all want them to have choices, and that means supporting a competitive health insurance marketplace that provides that choice. I'm grateful for your leadership, Chairman Alexander, and I'm so thankful that we're finally moving in the direction of working together to find real solutions to ensure all consumers have access to quality, affordable care. Thank you.
Thank you, Ms. Miller. Mr. Doak, welcome.
Thank you, Senator. Good morning, Chairman Alexander, Ranking Member Murray. One of the things, I think, before we get started today, our hearts and prayers are with those folks that are in the line of the hurricanes, and we want to keep them in our prayers today, and would ask for speedy consideration for the Flood Reauthorization Act with all that on our minds. Well, good morning. I appreciate the opportunity to testify today to provide an Oklahoma perspective on stabilizing the individual health insurance market for 2018. For years, Oklahoma has been dealing with the negative consequences of Obamacare. I've been warning about spiking rates, narrowing networks, rising deductibles, general market instability for too long. My warnings have been ignored at the federal level. I look forward to seeing how Congress will finally address these problems in time for carriers to meet their 2018 deadlines. The implementation of Obamacare in Oklahoma has been a failure. It has created severe market disruptions without meaningful reduction in the number of uninsureds in our state. In 2014, our citizens chose plans from 5 different carriers on the federally facilitated marketplace. Those carriers sustained heavy losses, and by 2017, that number had dropped to only 1 carrier. What's happening now can't be sustained, and we can't expect eventually Oklahomans will have no market and no options. Not only do Oklahomans have 1 marketplace carrier to choose from this year, but over the past 4 years, rates on our marketplace have increased by 130%. Studies estimate that approximately 30,000 individuals who do not qualify for premium assistance exited the non-group market in Oklahoma between 2016 and 2017. Small business owners and self-employed individuals, who are the backbone of Oklahoma's economy, are suffering. As premiums have spiked, enrollees have experienced deductible shock and can't afford the coverage. Many people in Oklahoma, where the average per capita income is just above $25,000 annually, are being forced to pay higher premiums for a policy they cannot afford to actually use. Further, as carriers have sustained large losses in the marketplace, they have responded by narrowing their provider networks. It turns out you can't always keep your doctor. Many other states are facing similar issues. Unfortunately, all recent efforts to repeal and amend Obamacare have failed, and states like mine have been left holding the bag. I'm encouraged by the Trump administration priorities, particularly in encouraging state flexibility and autonomy. In Oklahoma, Obamacare gives us no other options at this point. Oklahoma has submitted a 1332 waiver application under the Obamacare framework. This application focuses on the creation of a market stabilization program using federal pass-through funding and state-based assessments. This would create a reinsurance program for carriers operating in the marketplace. This initial plan estimated to reduce premiums and increase enrollment in the marketplace in 2018. Subsequent waivers will regain state control over other Obamacare requirements. However, I am not convinced that Obamacare waivers are going to be the solution to our problem. What we really need is an innovative, long-term solution that truly returns powers back to the states to implement ideas tailored to fit each state's specific needs in health insurance. That's why I've been encouraged at proposals that are out there, like ones from Senators Graham and Cassidy, which would repeal the individual and employer mandates, block grant dollars to the state, this kind of leadership and flexibility to the long-term stability of our markets. If some states want to keep their regulations from Obamacare, that's great. That works for them. But that isn't working for Oklahoma, and we should have the opportunity to do something different, or else we face an uncertain and difficult future on this current flawed path. In conclusion, former Senator Dr. Tom Coburn recently said, "If you want to fix health care, fix the markets." I do not think government will ever fix health care. Only markets will. For more information, please see my written testimony, which includes letters I sent in January to House Majority Leader McCarthy and Chairman Alexander. These letters outline several other innovative solutions to our insurance problems. Thank you very much, Mr. Chairman.
Thank you, Mr. Doak, and thanks to each of you. We'll now begin a round of 5-minute questions. We'll begin with Senator Enzi.
Thank you, Mr. Chairman, and I want to thank the panel for not only what you've said, but what's in your testimony, and it will be helpful to us in a number of solutions. I'll begin with Ms. Wing-Heier, and I know that Alaska's been faced with some dramatic premium increases in the country and potential loss of carriers on the exchange. And you set up that reinsurance program to address premiums and working through that Section 1332 waiver now that also includes several market reforms. Can you talk about what you're seeing from the waiver and what you might look for and what some of the impediments might have been to getting the waiver?
The waiver process is somewhat onerous in the fact that there is not a defined application to submit. So the states that are applying are hoping that they are providing the data requested by CMS, including the actuarial analysis, the economic impact, and proving that they are staying within the guardrails to be given the waiver. After that is done, the part that is stifling states right now is the 6-month waiting period before they receive final approval. The first part of the waiver, as far as the application, the actuarial analysis and such, can be done in a period of a couple of months. But then you wait after CMS is giving the first approval for up to 6 months to know if you will receive final approval, your funding, or the ability to go forward with any state innovation that you may find would benefit the citizens in your state. I will tell you that CMS was very helpful to us, but it still was a rather lengthy process.
So you can probably provide us some suggestions, as you just did, for simplifying that process.
We submitted and worked with CMS on some reforms that we thought would help. I do not believe they've been adopted. I'm quite sure they have not been adopted, but we did submit some comments to CMS on things that could improve the waiver process.
Thank you. Mr. Doak, Oklahoma faces some similar challenges to Wyoming. We're practically neighbors, and we have only one insurer offering individual coverage on the exchange. Can you talk about the challenge that it creates with one carrier holding all the risk? I know that Wyoming's Blue Cross sustained some real losses last year, and I might talk about those later, in their first year as the only carrier offering coverage. What changes would you suggest that could encourage more competition in the individual market for states like Oklahoma and Wyoming? I know you had some of that in your testimony, if you could share that with us.
Yes, sir, Senator. Thank you very much for that question. And we do share some of the similarities with your state. While our Blue Cross has had a huge amount of losses, much like yours, one of the things that I think that we can do is, as long as we're under the current framework that we're operating under Obamacare, the 1332 waiver is, and funding the CSRs is the right way, the path to go ahead, unless we make other dramatic changes in the future. And in my letter that you stated, I see many options for Oklahomans in the future to be able to, again, small businesses in Oklahoma are really bearing the brunt of many of these unintended consequences. So I think that associational health plan bills, other types of vehicles that can be used, I, for one, believe that buying across state lines is a possibility. But again, also offering maybe more catastrophic type plans, as we talked about earlier this morning, for Oklahomans to be able to have choices for what types of carriers and services and deductibles they have. The more choices we can give consumers, in my opinion, is the right thing to do for my state and others.
Thank you. I noticed that Ms. McPeak mentioned a stop loss at a specific amount. Mr. Kreidler mentioned a federal stop loss, and unusual market changes were mentioned by virtually all of you. I know in Wyoming we had a carrier that found out that two boys each had $30,000 prescription each year, but that was bought out by the primary company, so the generic went away and it went to $1 3/10 million each. So they had a $2 6/10 million hit from just one family. So I appreciate your comments on that, and my time is about to expire here. I will be asking in writing for some suggestions from you on ways to do that stop loss at a specified amount, and how the federal government ought to have a role in it, and what the state role should be. Thank you.
Thank you, Senator Enzi, and thank you for staying within 5 minutes, setting a good example. We have lots of senators here today. Senator Casey.
Mr. Chairman, thank you. I want to thank the chairman and ranking member Murray for making this hearing possible and the subsequent hearings, as well as the roundtables. It's when I was going across Pennsylvania in August, I was in 32 of our 67 counties, and when I could announce that we're having bipartisan health care hearings, was an audible sigh of relief. So we're grateful for the opportunity. Secretary Miller, I wanted to ask you in particular about that we've got, I think, a broad consensus emerging, at least, about the importance of the cost-sharing reduction payments, the so-called CSRs, and I think more discussion now as well about 1332, the waiver. You said on pages 6 and 7 of your testimony that you felt that the 1332 waiver process could be streamlined to minimize administrative burden, I'm paraphrasing here, while also protecting the guardrails of the waiver program. Can you walk through that, in particular the concerns you have about maintaining those so-called guardrails? Explain that.
Thank you, Senator Casey. I think from Pennsylvania's perspective, as we think about potentially looking at a 1332 waiver, the current process is very cumbersome. We would have to pass legislation, we would have to go through public hearings, and then go through the process that I think Alaska's familiar with in terms of working with CMS. So it's a long process to get there. I think the more we could streamline that process, the better off it would be. I think if states have the opportunity to submit a letter from their governor as opposed to having to pass legislation to move forward on a 1332 waiver, that would be very helpful in allowing us to respond to market changes and trying to make sure our markets are stable going forward. I don't mean to sound greedy, but if we could have some planning funding available to help us really think through how this would work, I think that would also be very helpful. Also having flexibility around the 1332 waivers and 1115 waivers, the Medicaid waivers, to think about those in conjunction in terms of the budget neutrality requirements as opposed to looking at them individually for those requirements. But I think as we move forward
Could you explain what you mean by that, please?
Sure. So the 1332 waivers and the 1115 waivers each have requirements for budget neutrality. And I think for states, if we want to be even more innovative, being able to think about those waivers together instead of having to think about them separately, and having the overall budget neutrality requirement looked at as a pool, and from just a strict is this budget neutral together would be very helpful, and it would allow states to be more innovative in thinking about that. But I do think, to your point, Senator Casey, I do think that the baseline coverage requirements are really important, and ensuring that whatever we do doesn't result in fewer people covered or doesn't erode the coverage. I think, a lot of us up here hear from consumers on a regular basis about high deductibles and concerns about other out-of-pocket costs that maybe they don't expect when they go to use their care. So I think we want to keep those baseline coverage requirements intact as much as possible. But the more we can streamline that process, make it easier for states to respond to market dynamics, that would be helpful.
The other thing I want to ask you about is what happens to folks in the age category 50 to 64. We know, for example, that the rate of uninsured adults ages 50 to 64 dropped by some 47%, from 11.6 to 6.1% between December 13 and March 15. Obviously good news there of a huge drop by almost 50%. In the context of your experience in Pennsylvania, how has Pennsylvania stabilized its marketplace while also protecting older Pennsylvanians who are not yet eligible for Medicare, meaning that 50 to 64 age category? How have we done in terms of accessing more affordable care?
So I think the current system protects older Americans and older Pennsylvanians. I think the 3-to-1 age band that we currently have in the ACA helps make sure that older Pennsylvanians can afford that coverage. I think a lot of us, as we think about stabilizing these markets, are really focused on getting more young and healthy people into the risk pool. And I think if we can find ways to do that that are not on the backs of older Americans, that's the way to do it. I think a lot of us have talked about expanding enrollment, funding, advertising, and funding navigators so that we have assistance getting people enrolled. All those are ways that we can boost enrollment without doing it on the backs of older people.
Great. Thank you, Mr. Chairman.
If you have another question,
I'm good.
okay, thank you. Senator Paul.
I think the chairman's done a good job at sort of focusing on the problem, and so is the panel. You know, the problem's in the individual market, and it's 6% of the marketplace. I think, though, that we have ignored sort of what's working in the insurance market. There are parts of the insurance market that are working. Maybe we should look at those and try to figure out how we get more people into the parts of the marketplace that are working and how we get them out of the marketplace that's not working. So 6% of the people in the individual marketplace, 36% of the people are in the large group self-insured marketplace. This is sort of the ERISA marketplace. And I think you can make the argument that it works better than anything else. Probably has the lowest increase in rates over time. People are protected. They have large groups. They can have leverage to get cheaper prices. They have a pool of people they're a group of where they're protected against one person getting sick. So I would argue that the worst place and the possible place in the whole world to be is in the individual market. You shouldn't want to be there. And my question is a more fundamental question. Can you fix it? And is it morally or ethically right to take money from the taxpayer and give it to insurance companies to subsidize people in the individual market? Maybe we ought to give people an exit. Let's let people get the hell out of the individual market. Mr. Doak has talked a little bit about this with the health associations in his state. I'd go a step further. There are 2 million fast food restaurants in our country. About 15 million people work in the fast food industry. These are our lower wage working class citizens. These are the people who are struggling. These are the people who are still not even insured under Obamacare. These are the people we should want to help. Let's let them become part of the ERISA plans. Let's have nationwide health associations. What if one person were negotiating for 15 million people, fast food restaurant workers? You're bound to get a better price. It's the phenomenon of Walmart. Walmart gets a bigger price because they are a bigger purchaser of things. Let's legalize that. It would cost the taxpayer nothing. Let's just say people can associate with other people and buy insurance. Get the heck out of the individual market. I would prefer there be no individual market. I think it's an artificial construction of attaching insurance to your taxes. When we did that, we created the individual market, and then we have big insurance comes to Washington with their hands out. They made $6 billion a year in profit before Obamacare. They now make $15 billion a year. CSRs are money you are giving to the insurance company. All this money is being given to big insurance. Don't give it to them. Let the individuals get into the group marketplace, and guess who pays for that? It comes out of the $15 billion in profit they make in the group market. What a scam. They come here and they make tons, billions of dollars in the group market, but then they whine they can't make it in the individual market. They cherry pick, they love the group market, and they stay in it, and they say, hey, we're not going to sell it in the individual market. Well, let's equalize the individual and give them the power to negotiate with the insurance company. Doesn't cost anything. All we're doing is legalizing collective bargaining for consumers. We should like it on this side of the aisle. And while Senator Sanders and I don't often agree on things, if there are a few people left that you can't buy that are uninsurable or have a pre-existing condition, I would rather buy them health care than give money to the insurance company. It makes no sense to try to buy insurance for people who cost $1 million a year who we already know what's wrong with them. Put $1 million in for somebody who costs $1 million, buy them health care, don't buy them insurance. You can do all these fancy reinsurance things and all these backstops. They don't work. We're subsidizing an individual market that does not work. It just is a non-functional, you can never get there. People say it's too expensive. Well, new cars are too expensive. Why don't we subsidize and have a stabilization fund for new cars, for iPads, for iPhones, college education, anything that costs too much? We could just put a bunch of taxpayer money in and say we're going to make it lower by giving money to the people who provide these things, people who make the iPhones, people who supply college. So I think we ought to look at it a different way. Let's don't try to fix the individual market. Let's try to give people an exit ramp to get the heck out of the individual market completely. For those who can't or who don't, that we have to provide health care for, why don't we look at actually buying health care for them rather than buying insurance for them? Mr. Doak, if you want to respond, if you have any numbers on what your health associations have done and whether or not it's put a little bit of a dent in helping people from the individual market get into the group market, I'd appreciate it. Thank you.
Yes, sir. Thank you. At this current time, the Oklahoma Health, we have the legislation in place at the state level, but there are some frameworks around the bona fide, the actual definition of an association, which I think needs closer scrutiny to be able to open up. I do agree with you that associational health care plan bills, while I may differ from my colleagues respectfully, but I do think that that could be a very viable market for folks to band together, whether they're, as you mentioned, folks in the restaurant business or they're from the flower industry, wherever that might be, to band together to purchase coverage. And we know that there's folks that can facilitate that in the marketplace. So I do agree with you on that, Senator.
Thank you, Senator Paul. Senator Franken.
Before I begin, I want to thank you, Chairman Alexander, and I want to thank the ranking member, Senator Murray, for holding this series of hearings on individual insurance market reforms. Healthcare is such an important personal issue that affects millions of Americans, and that's why I'm heartened that we're having these bipartisan hearings to discuss common sense reforms that will stabilize markets and lower health care costs for consumers. I just wanted to spend a moment on the correct pronunciation of insurance, which is insurance, not insurance. Now, thank you. Now, whether the commissioners here today pronounced it correctly, I think you all agree that we should have reinsurance or reinsurance. And I believe that all but Mr. Doak, who, by the way, mispronounced it, spoke explicitly on the importance of continuing cost sharing, and all of those who talked about it, cost sharing for multiple years. Now, Mr. Doak, is that just are you for continuing the cost sharing?
Is that Franken or Franken? I'm sorry. I think, yes.
I can't mispronounce Doak.
Yes, that's good. That's good, sir. With my position is, under the current Obamacare network, we must continue under the current framework that we're working under, unless it's changed. We do need to continue the cost-sharing agreements. I think we have consensus.
Good. So we all have consensus on this panel of actual people who do are heads of insurance in their states, that we should continue cost sharing and that we should do reinsurance. So, Commissioner McPeak, it's nice to see you again. As you know, Minnesota has applied for a 1332 waiver to set up a federal state reinsurance program to help reduce health insurance premiums. My hope is that the administration will approve this waiver quickly. As documented in a New York Times article that ran this past weekend, my state insurance program has bipartisan support, passed in the state legislature with bipartisan support, and if approved, it would reduce health insurance premiums by about 20%. And as the article notes, this reduction would help all Minnesotans buying health insurance on the exchange, not just those with the most costly health care needs. Other states, like Mr. Doak's Oklahoma, are considering similar proposals. Senator Alexander, I'd like to ask unanimous consent that this article from the New York Times be submitted for the record.
It will be.
Commissioner McPeak, in your testimony, you talk about the importance of federal reinsurance, of the federal reinsurance program, or a federal reinsurance program. What advantages does a federal reinsurance program offer compared to a state-based approach?
Thank you for the question, and I will try to pronounce insurance correctly, but I am from the South, so I don't have any guarantees there. I will say the federal reinsurance program has a benefit for states like mine that may not have the ability to upfront the seed money to get our own program started, even in the 1332 waiver process. Then, to use the waiver process to create our own state fund would require the legislative approval that can sometimes be very difficult to obtain, even when your legislature in the state is in session, which ours is not again until the first of the year. I see the additional benefit of the reinsurance program not only to reduce premiums for consumers, but I think that it would add market competition. It would entice insurers back into the market because it would provide the economic certainty about a stop-loss attachment point for a reinsurance program so insurers could better estimate the risk of entering the market.
Would anyone else care to, Ms. Wing-Heier, I know that Alaska has a reinsurance program. You've had the 1332 waiver. Would anyone care to talk to the wisdom of a permanent federal reinsurance program like the one that was established under Medicare Part D? Mr. Kreidler, I see you nodding. I like people nodding when I say something. So you want to?
Certainty is one of the things that we're really looking for 1332. You know, tell us what, if our application is going to be accepted, tell us whether it meets the criteria. Speed is what we're really interested in answering it. We're exploring it right now as one of our options in the state of Washington. We're also looking at a public option, and particularly in counties where there aren't any other insurers that we can make available, either through our public employees or expansion of the Medicaid program, or we have a high-risk pool, some other way of being able to guarantee it. But when it comes to the 1332, because of the 6-month waiting period that we have right now on filing the application, because we have to go back to the legislature, it really compresses. We're trying to make a difference and see if we can make a change for 2019. We won't be able to do it for 18, but we're pretty confident in our state that things are going to be stable for 18. We're really worried about what's going to happen in 2019. Getting the CSRs funded will help in 18 because it starts to restore their confidence. But give us some certainty on the 1332 waivers. We don't want to see our backs turned to the issues of the essential health benefits or the protections on out-of-pocket expenses.
The guardrails that Wing-Heier talked about this morning.
Exactly, and you've heard that from other commissioners too. We're concerned about the guardrails that they're not eroded away.
Well, I'm out of my time. Just want to say one thing, which is that all of these things, cost sharing, reinsurance, have virtuous cycles that bring down the cost of premiums and ultimately bring healthier people in, and so do enforcing the mandates, and so does more advertising and more people to help you navigate. So that's what I'm for. Bye.
Thank you, Senator Franken. Senator Collins.
Thank you, Mr. Chairman. Commissioner McPeak, it's good to see you back again.
Yes.
I want to follow up on the reinsurance issue as well, since the soaring cost of premiums in the individual market is a major concern of mine, and I would say of all of us. We heard today of the success of the reinsurance pool that Alaska set up. Similarly, Maine, between 2012 and 2013, had a reinsurance pool that was successful in lowering rates in the individual market by 20% on average. So I think if you look at the experience of those two states alone, it shows the benefit of reinsurance pools. As a practical matter, however, many states are simply not in a position to immediately stand up a reinsurance or high-risk pool. Therefore, I have two questions for you. One, do you see a role for the federal government in the short term in either establishing a high-risk pool or assisting states in doing so? And second, the analysis that I have seen by Milliman has suggested that the cost to replicate the kind of reinsurance pool that Maine had would be about $15 billion annually. Does the NAIC agree with that? And could you comment on both those issues?
Certainly. Thank you for the question. I do believe that the reinsurance mechanism or a high-risk pool, either one, has the effect of removing from the risk pool the highest cost claims, which provides certainty to insurers, helps them actually price products for those other individuals in the risk pool, and so it should bring premiums down remarkably. Plus, as I said, I think that it would also entice insurers to write in areas where you had very limited options, because you have an idea of what your ultimate risk might be for writing in that area. As for the Milliman report, I don't know that we have provided any analysis on that figure. $15 billion does seem like that would be a good place to start to set up a federal mechanism until states could get on their feet to have their own system, which might be a reinsurance program, or it could be a high-risk pool, depending on the individual state needs. I think Tennessee, we would be more interested in creating a reinsurance program, but as you mentioned, we don't have the ability to set that up immediately, and certainly not to affect the 2018 rates.
Thank you. Ms. Wing-Heier, thank you for being here and sharing your experience. One of the keys to driving down rates in the individual market is to broaden the market and to get as many people as we can enrolled. So let me ask you about two ideas. And one comes from conversations that I've had with insurance experts in the state of Maine. Right now, under the Affordable Care Act, if you are over age 29, you cannot purchase the copper plan and get the subsidy that would be available even if your income would warrant that subsidy. And if you don't qualify for the subsidy, you're also prohibited from buying the copper plan unless you're under age 29. Should we change that is my first question to you.
We believe that being able to have a catastrophic or copper plan available for a younger population is beneficial to growing the market, getting the healthier individuals in. We also think that it should probably be combined with a health savings account. And it will be somewhat of a learning experience for the younger population, the healthier population, to come in, purchase insurance that they're not now, mostly because of the prohibitive cost. So we are in support of finding, if you call it the copper plan or a catastrophic plan, bundled with an HSA for the younger population.
That's a great combination because then the HSA can be used to help pay the out-of-pocket costs. Ms. McPeak, I have only 8 seconds left, so you may have to answer this for the record. But another idea which Senator Cassidy and I proposed many months ago was auto-enrollment instead of an individual mandate where someone could opt out. But we know from the experience with 401k plans that if people are automatically enrolled, they are likely to stay enrolled. Do you have any thoughts on that as a way to help broaden the individual market?
I will just say very briefly, I do think that auto-enrollment could assist people in staying enrolled. The issue is if we have more than one carrier, which I hope that we are returned to that competitive environment someday, I would like to have the ability for consumers to choose, because there's such detrimental options with provider networks and drug formularies that I would want to have some ability to make sure that you are enrolled in a plan that works for your family.
Thank you.
Thank you, Senator Collins. Senator Bennett.
Thank you, Mr. Chairman, and I also want to thank you and Patty Murray, the ranking member, for holding this hearing. It is long overdue that we begin to approach this in a bipartisan way, and I was so pleased to see so many senators at the session this morning that you held that suggests very strong bipartisan interest in trying to figure out how to fix this. I also think it's important to underscore something you said at the beginning of the hearing, Mr. Chairman, because it's an important perspective for people to have. We are talking about 6% of the folks that are insured in America. And if we can solve these issues for that 6% in a bipartisan way, that would be a very important book of business for us to take care of. But it's not the end of what needs to be done. And when I hear from people in my state, whether they support the Affordable Care Act or whether they oppose the Affordable Care Act, they are deeply dissatisfied with the way their lives intersect with America's healthcare system. And I think it's because they know they are being forced to make choices that people in other industrialized countries do not have to make about healthcare, about their business, about the predictability of being able to go to a doctor. And a lot of that has to do with underlying costs in our healthcare system and a lack of transparency in our healthcare system that we still have not found a meaningful way to address. So my hope, more than a plea, is that once we get this piece of work done, that we will continue to work in a bipartisan way to try to deal with the root causes of what this panel is talking about today, which is that we spend too much money on our health care without getting the result that we should have reason to expect. The question that I'd like to ask for you, the panel, is that, to me, the most solid critique of the Affordable Care Act, as opposed to our health care system generally, is when people say to me, Michael, you're forcing me to buy something, insurance, that it costs too much because there's no competition in my area. This is very often in rural parts of the state, in mountainous parts of the state. And the deductible is so high that it's of no use to my family. And I think that is a legitimate criticism of the Affordable Care Act. I was somebody who supported the Affordable Care Act, but I'm willing to take criticism. And so the question is, how do we solve that problem? How do we introduce more competition into these rural areas than we have to drive the price down? And Mr. Kreidler, maybe I'll start with you, just because you were saying that Washington State was considering the possibility of a public option for some of these counties. I'd be interested in other thoughts that other folks on the panel have as well. I understand the backdrop of reinsurance and all of that. We probably don't need to revisit all of that, but just specifically talk about what's happened in rural areas.
Thank you, Senator Bennett. Something to remember is that rural counties were a problem before the Affordable Care Act. They've been historically a challenge for every state. We have 9 states right now, or 9 counties right now that have only one insurer in them, and they're all rural counties.
We have 14, and it's the same.
Yes, yeah. And I think what we can wind up doing is offering some incentives for carriers to go out there, but then there's always the potential of looking toward a public option, and that's what we're considering right now in the state of Washington, a very broad group of insurers and providers. The Health Insurance Exchange is working very closely with us, and we're doing a joint effort here as to how we can analyze the various options. 1332 waiver is one of them. I don't know if it'll work for the state of Washington, but we do have the opportunity here to take a look at a public option that might exist for those counties, so that we're offering them something which is right now not acceptable to be in a position either with very limited competition or no competition.
Do you need the 1332 waiver to do the public option, or are those two separate ideas?
These are two separate ideas.
Thank you. I have 1 minute left if there's anybody else who'd like to answer.
I would just say there was a bipartisan group of governors that sent a letter to Congress last week, and in that letter they have some recommendations around offering choices in underserved counties. And one of the proposals, which I thought was interesting, was allowing residents in underserved counties to have access to or to buy into the federal employee benefit program. So I think ideas like that would be great places to start.
Ms. McPeak, did you have something quickly?
Thank you. I would just like to suggest that if we could provide some flexibility to states to provide maybe a less robust schedule of benefits still within the EHB categories, but providing first dollar coverage for things like preventative care, but on a lesser scale than what is currently in the market in the Silver Plan, that it could really attract a lot of folks into the market with a more affordable option. Because we hear the same thing that you do, is that I'm forced to buy something that at the end of the day I really can't use to access health care.
And I'm out of my time, but I just would respond to that by saying also that it is really important for Americans not to be forced to buy lousy insurance, insurance that no one else in the industrialized world has to settle for. It needs to be real, but I appreciate the desire for flexibility. Thank you, Mr. Chairman.
Thanks, Senator Bennett. Senator Murkowski.
Thank you, Mr. Chairman. I want to follow up with some of the comments that Senator Bennett has just made, and also to thank the chairman and the ranking member for this very important beginning of a good constructive dialogue. But speaking to the issue of how we deal with those in our rural areas, and of course, Alaska is always on the poster child when it comes to real rural. When we're talking about our individual market, it is a group of 18,000 people. We cannot construct a market off of 18,000 people. So in Alaska, we've been looking at, well, where could they fit? So I was actually pleased to read the letters from the governors in suggesting that maybe it might be a workable idea to have residents in underserved counties to buy into the federal employees benefit program. I don't know if that's I don't know if that's the place. I don't know if it's the state employees program. I don't know if it's the other programs that we have out there. We've got a big VA population in Alaska. We have a big population of our native people that are served through IHS. So trying to construct something for 18,000 people, to me, just doesn't seem like a measure that works. Another proposal that has been out there a lot, and Mr. Doak, you raised the opportunity for purchasing across state lines. And Ms. Wing-Heier, I'd like you to address that as a viable alternative for us in Alaska. As people have asked me, I've said, we're not attractive to anybody. We are high cost, we are high risk. Why does anyone want to adopt Alaska into their pool? But is that something that has merit, even for a state like ours?
It could possibly have merits. There is some concern with consumer protections and selling across state lines, which we've discussed. But Alaska is unique in the fact that when insurers look at us as we are right now, I don't know that it's going to matter if we're joined with a Wyoming or an Idaho. I mean, we have looked at possibly doing a co-op or an arrangement with other western rural states to see if we could come up with the numbers that 18,000 here, 20,000 there, if we could develop our own co-op, so to speak, of insurers, enrollees. But we still have not come up with the numbers, and right now our experience has been so bad that you're exactly right. When we have talked, no one's wanted us because of our cost of health care. And what that translates then into insurance. We would be bringing the rest of the market down. And that is not a position we want to be in. It's the fact of living in Alaska. Very rural, limited facilities in very rural areas that are hard to access. There's no magic answer for us. But selling across state lines is certainly something we could explore. But right when we have talked prior to insurers and when we have talked to other states, we have not been an attractive risk.
Let me ask about the issue of cost share. It has been raised by everyone. I think we recognize that uncertainty within the market is deadly. You cannot move with accuracy. There have been some that have suggested, I believe it was the chairman in his remarks, said that we need to extend the cost share subsidies through 2018. 2019 is another date that has been out there. I think that the governors, in fact, ask for extension at least through 2019. If we were to do it just through 2018, does that provide sufficient certainty? Or does it need to be longer year, 2019 or even beyond, to give the certainty? Right now, we're going month to month, and we know that that doesn't work. So can you all speak to that?
I believe it has to be at least 2 years. I think that right now there's enough consternation in the market that the insurers looking to remain are looking for more than a 1-year commitment.
I'm seeing 2 head nods, at least 2019.
Senator, I'd say it even needs to go further than that because insurers right now are already planning the 2019. So we're already, so to speak, 2 years out already in order to give them that predictability, you have to give them a little bit more certainty going into the future that it's going to be there, so that they don't bolt and leave the market. And that's the biggest concern I have, is that somebody will yell fire in a crowded theater and they'll all leave. And we've seen it happen in Washington State in the 1990s, and it shouldn't be replicated for the rest of the country.
Thank you, Mr. Chairman.
Thanks, Senator Murkowski. Senator Baldwin.
Thank you, Mr. Chairman, and I want to underscore what many of my colleagues have already said, that I'm deeply grateful for your bipartisan leadership, both of you. I really believe we can find common ground to stabilize the health insurance markets, to improve coverage, and to reduce costs for the constituents we represent. Yet while this committee is working together to achieve this goal, the administration continues to play dangerous political games that are destabilizing the market and causing premiums to rise. Wisconsin insurers are requesting between 10 and 46% premium increases, and they are pointing to President Trump's failure to provide certainty in the markets and the threats to end the cost-sharing reduction payments as they announce these plans. I would also note, in addition, it's gotten a little bit less attention, although some of you did raise it in your testimony, the 90% reduction in funding for enrollment programs that get the word out, especially to young people and healthy people, to help with the enrollment process. The cuts to the Navigator programs that in my state have provided such useful assistance to those enrolling, the shorter enrollment period, all of these add up, and beyond that, then the issue of whether the individual mandate will be enforced at all. So I want to focus a little bit more deeply on some of those today, and invite my Republican and, frankly, my Democratic help colleagues to partner as we explore policies to enhance enrollment, again, particularly among young and healthy people. Mr. Kreidler, can you talk, why is it critical to market stability and affordability, particularly in this upcoming 2018 enrollment period, to boost the coverage of younger and healthier individuals? And what do we need to do in this stabilization effort that we're talking about on a bipartisan basis to achieve that right now?
Senator, it's critically important that you have good risk along with bad risk in the insurance pool. You can't, if you only have bad risk, no one can afford the insurance. You've got to have good risk, and typically the younger individual is going to represent better risk in the overall market as opposed to somebody who is older. So one part of that is certainly doing the kind of outreach effort. Now, we're a state exchange. Not all, I think I'm the only one that does have a state exchange here at the table. So I'm not in the position of really having to rely on the federal government, but there are a lot of help that come because of the marketing approaches that they've taken at the national level that have, we're in the slipstream, we pick up benefits even though we have our own state exchange. So I would certainly encourage that we continue to have a very strong outreach, that it allows us to really get the message out to individuals. There are problems with individuals to sign up for it if they're younger and healthier. We need to make sure that they get health insurance. If they need to listen to mom on these issues, and that health insurance is something you shouldn't be ignoring. And to the extent that that message is being delivered, it becomes much more effective.
That's great. Ms. Miller and Mr. Doak, for both of you, I'd like to hear your comments on this because, as noted, Washington has a state exchange. You're working in a different context.
Thank you. I think from Pennsylvania's perspective, we are very concerned about the decrease in funding for for advertising for the exchange, which we rely on, for the decrease in funding around the navigators and the critical assistance they provide to get people enrolled. All of those things, I think we're very concerned about the mandate and the enforcement of that mandate. That has an impact on premiums, and even if we get cost-sharing reduction payments paid into the future, which is critical, I think there's still a lot of concern, and we hear from our insurers in Pennsylvania that because we're not sure how effective that mandate is going to be going forward because of all the conversations about eliminating it, I think we're going to see that uncertainty built into our rates going forward. So that's a major concern for us.
Senator, I'd just like to make a comment regarding a couple of your earlier statements. We're here because of many things have failed. We've had increases in Oklahoma even while we've had cost sharing in place. And your other comment about navigators is I would ask for the full Senate committee to do an audit of the navigator program to find out, one, are they doing the job that they're supposed to be doing? Where's the checks and balances there for the millions of dollars that have been spent in that area? Has it achieved the outcomes that you thought it did? One, navigators are not incentivized regarding health care. I fall back to the position of that always should have been handled by licensed agents and brokers in the United States, and in particular in Oklahoma, because I've been in every county of Oklahoma, all 77 counties, and there's an insurance agent on every corner that's readily available, and they're the insurance professionals that should be helping folks. So I would just ask, I think that the Navigator program needs some oversight, and that's one of the things that we're going to be looking at in Oklahoma is where those dollars were spent and were they worthwhile.
Thank you, Senator Baldwin. Senator Cassidy.
Hey, folks. I had the privilege of being with y'all this morning, so some of what I say will be built upon that. I'm going to set a context and lay out 3 questions and ask you all to respond very quickly and concisely to that which you pick. We spoke this morning, Ms. Miller, regarding the individual mandate. Now, Jonathan Gruber, the so-called architect of Obamacare, has an article in both the New England Journal of Medicine and the NBER, which says that the individual mandate really doesn't do diddly squat. It is actually governors. If a governor gets engaged, my gosh, things happen. But the individual mandate, minimal effect. Now, then, as I've learned about this, Maine and Alaska have done great things, innovative things as regards the reinsurance program, which in turn have lowered cost and potential to increase coverage. So I say that, and here's the first of my 3 questions. In the Cassidy-Collins plan, in the Graham-Cassidy-Heller plan, we want to give states flexible block grants, allowing states to do what they wish to do. That's an overview, and my colleague from Maine may say, well, wait a second, there's a nuance here, and she's absolutely right. But the reality is we allow states to innovate. That's number one. Do you think, now, Commissioner, you had said earlier, well, you want to make sure the money's there. Okay, as much as possible, we know the money for Obamacare is there, but maybe not, because I can tell you it's already a little bit threatened. So let's just assume the money's going to be there. Would you prefer a flexible block grant? Could you do more with it? You got to spend it on health care. But secondly, I am concerned about Oklahoma, my state, Louisiana, ability to afford a 10% match on the Medicaid expansion. That 10% match on the Medicaid expansion is going to be huge. In my state, $310 million. We're an oil state, revenue's down, we're sucking wind right now. Can we afford that? And then thirdly, there is, even aside from expansion versus non-expansion, there's some states that have dramatically increased cost of care relative to others. And Washington State has done such a good job in controlling cost. Others, not so good. So how do we compensate for that? Should we attempt to equalize the payment that goes to states, or should we prejudice towards high-cost states, frankly, as opposed to those which manage costs well? Take your pick. You got 2 minutes, 45 seconds. Try and be concise.
I will begin. I will say that your comments on the individual mandate really reflect the experience in Tennessee. I don't know that it has driven a lot of our consumer behavior. We see a lot of our individuals being willing to risk the penalty for not having ACA compliant coverage, actually accessing other products available in the market, both non-ACA compliant plans or other cost sharing mechanisms which would still require a penalty to be paid if the mandate were enforced. I also ask our insurers to break out a provision on 2018 rate increase request attributable to non-enforcement of the mandate, and it was negligible. It was about 5% increase, where the CSR uncertainty was about 14%.
So really, it is the state kind of getting engaged. Any of
believe
my
so.
other points, what do you all think about it?
Senator, I might just respond to your comment about the cost of the expansion is that I think I was trying to find some notes, and we'll get it sent to you, but I think former Oklahoma Governor Frank Keating wrote a really good article on the ultimate cost to the state of Oklahoma, which is something that needs to be taken into effect. On your other point, I am 100% in favor of all the funds coming to the state of Oklahoma, giving the state of Oklahoma, our legislature, our governor, and the people of Oklahoma the best ability to put together the best plan. If California wants to come up with a universal health care, let California do that. If Washington, my friend from Washington, if they want a different type of policy, I think the laboratory of democracy and the success, we could all learn from each other, but get those monies back to the state where we can take care of Oklahomans.
Amen, brother. Anyone else?
Senator, I'd certainly hope that the block grants wouldn't vary from one state to another just because the
On a
state of
per beneficiary basis. You'd have to do it per enrollee, correct?
we do a good job in the state of Washington holding down spending on health care better than most states. It's really not appropriate that we should wind up being essentially punished for doing a good job.
So equity across states would you think would be important?
Equity, and make sure that it's guaranteed going forward so that we don't wind up seeing a diminishment as opposed to an entitlement program we have today.
Ladies, I have 20 seconds left. Any comments?
I would add that in the block grants that we would ask that you take into consideration the cost of health care and the ruralness of Alaska because of our cost of health care and the diminished facilities that we have just due to what Alaska is.
Simple answer, we do. I yield back. Thank you.
Thank you, Senator Cassidy. Senator Murphy. Good entrance.
My timing's never going to get better than that.
That's right.
Thank you very much, Mr. Chairman. Ms. McPeak, I wanted to ask you to expand a little bit on your opening comments in which you talked about predicting last year that your marketplaces were on the verge of collapse, and as you testified today, they have not collapsed during that time. And I guess it speaks to a worry that I have about how the rhetoric gets overheated with respect to the stability of these exchanges and the overall stability of the Affordable Care Act. I'm so appreciative of the process that both Senator Alexander and Senator Murray have begun, and I acknowledge the fact that we need to make some changes the Democrats want and changes that Republicans want in order to provide some certainty. But maybe you can talk a little bit about what happened over the last year. You said that you were on the verge of collapse. You didn't collapse. And what does that say about how these marketplaces are and have been holding together? Just tell us a little bit about that story.
Thank you. Well, certainly I'm very grateful that the market, in fact, in Tennessee has not collapsed, but I would still say that we're on the verge of being in a very difficult situation and probably still on the verge of collapse. What we have experienced is carriers fleeing the market year over year. We did have one of our 9 rating areas that didn't have any options when Humana decided to withdraw from the exchange earlier this year. We did, in fact, receive coverage for that area through one of our other carriers, but still 78 of 95 counties having one option on the exchange is not a place where I like to be. We need to have a competitive environment so that our consumers actually have choice and we can do something to address premium rates. When you have one insurer that is threatening to pull out of rating areas, it's very, very difficult to really challenge the rate increase requests that we are receiving on a lot of different factors, because the worst possible situation would be for a carrier to flee the market and our consumers not have any choice in the market. And we are still very much concerned about that possibility until the QHP contracts are signed at the end of this month by the carriers.
All right, thank you. Yeah, and I just think it's a caution for everybody to be a little careful about how fast we declare that the sky is falling here. The popular phrase is death spiral, and yet during a period of time that we've been debating the bill, there have been less and fewer bear counties rather than more. So I appreciate that explanation. Mr. Kreidler, I wanted to talk to you about the importance of advertising and marketing. I think Senator Baldwin raised this question, but you're an interesting state because you've got pretty much every type of population that exists, rural communities, suburban communities, communities with easy access to information resources, places where it's a little bit hard to get the word out. There's a study out of Kentucky that looks at what happened when the marketing efforts effectively stopped. You had a Democratic governor who was doing robust marketing, and then the new Republican governor has effectively shut down funding for ACA advertising. And what happened there was that there were 450,000 fewer page views per week on the website for the state marketplace. There were 20,000 fewer unique visitors per week to the website. And guess what? ACA enrollment fell by 100,000 people to 94,000 people in 2016 to now 81,000 people. So there seems to be a pretty direct correlation between telling people that these options exist and people actually going and taking a look at the information that would lead them to get coverage. That speaks to what's happening right now with a 90% reduction in federal funding. So I just would love to hear you talk about how you communicate effectively and how instrumental those communications are in making effective marketplaces that insurers want to be a part of.
Senator, actually, we saw an increase in the number of people who were signing up through our health insurance exchange. Even while the federal exchanges were showing a slight decrease, we were actually showing an increase. And I think part of that is that we do have a very active website through our health insurance exchange. It makes it very convenient and easy for people to go there and shop. It was not as robust an increase as we had anticipated, and that really is because of the effect that you have when they're doing it on a national basis, the kind of sharing of information and strategies going forward that really assist us a great deal and help to address the issues around language, which are a particular issue for many of us. And I think that's where we can really make a difference from the standpoint of getting people to sign up for health insurance. If you have that kind of outreach out there, it helps to offset the enforcement of the individual mandate. Though I'd argue quite strongly that you need an individual mandate that's effective. If it's not the one we have now, then you got to come up with something that's comparable.
I support the chairman's goal of getting a narrow package that can pass quickly, but I hope that we do include in our discussion this dramatic reduction in advertising and marketing funding, which I think does have a fairly dispositive effect on the health of these exchanges. Thank you, Mr. Chairman.
Thank you, Senator Murphy. Senator Burr.
I've listened intently to this discussion, and I'm reminded as we talk about how to bring health care costs down that each state is unique. But health care cost reduction is a function of a change in outcomes. Change outcomes, you change the cost of health care. So let's not lose focus on what the most important thing is. But Ms. Miller, I've got to admit that I was moved by a statement you made that everybody should be able to buy into FEHBP that can't fit in a box. You know, I came from the private sector, and my experience in government is my health care went up and my benefit went down. Then the ACA came, and I'm now a participant in the DC exchange, and my premium and cost went up, my deductible went up, and my benefits went down. I would love to buy into FEHBP as a member of Congress again, wholeheartedly. I'm not sure that's the answer, though, for a population that's scattered, most of it rural, most of it without the delivery system that's needed to change the health outcome. So this is not just about coverage. This is about placing them in some type of delivery system. So I'm going to start at this end. I'm going to go up to Mr. Doak. All I want to know, yes or no, are you supportive of your state having control over how your health care plan looks in your state? In other words, you got a 1332 waiver or 1215 waiver. You can decide exactly how it's going to look. We'll figure out the financing. Yes or no, Ms. McPeak?
Absolutely. I think Tennessee can better manage our health outcomes for our consumers.
Mr. Kreidler?
I'd very much like to see the answer would be yes, but let's make sure we protect consumers and not take away their protections.
You would have full control over that, so you'd be the one to be held responsible, Ms. Wing-Heier?
One state size does not fit all, and Alaska needs to be in control of its health insurance program for its residents.
Ms. Miller?
As long as we're not talking about reduced federal funding and requiring states to come up with that funding, which Pennsylvania couldn't do, then yes, I think we are in a great position to regulate our markets.
All right. So we've got agreement that one of the things we should look at is to empower states to design their health care, to structure their health care system to meet the unique delivery system capabilities within their states. I think we've made tremendous progress. He already answered that they were supportive of it. That's what I played off of. Ms. McPeak, in order to solve the healthcare crisis facing our country today, we need to think of ways to leverage all of the new tools provided through innovation in healthcare. Insurers have access to tremendous amounts of data on the individuals enrolled in their plans in a way that wasn't imaginable just a decade ago. With this new information, healthcare insurers have the opportunity to design plans that incentivize the best possible health outcomes for their customers. As an insurance commissioner, have you had an opportunity to review plan designs for your state?
Well, no, unfortunately, in the individual market, the carriers are limited by the ACA to the plan design and underwriting factors in the law. So the
you
data.
Believe that should be also a function of the commissioner in the state?
Absolutely, I do.
Is that, in your estimation, a way to leverage healthcare data to offer more health insurance?
I do, and actual benefits that are accessible and usable by our consumers.
Do you believe you have the tools you need to review innovative plan designs working to keep pace with the new capabilities of healthcare data?
I believe we do because we review those plans and rates for the employer markets and small group markets already today.
I'm reminded that we're headed for a decade of disruption where technology is going to impact every sector of our economy, probably healthcare as big, if not bigger, than anywhere else. And some of the challenges we're trying to build into our construction of policy today will be trumped, for the lack of a better word, by our capabilities of connecting an individual in a rural or non-covered area where there's not a hospital, not a doctor, but because every American has this device, that there's going to be software that enables them to send their own vitals that are needed to a lab that will give them a reading without a hospital, without a doctor, without a nurse. How do we take advantage of this incredible innovation if, in fact, we've constructed in concrete what insurers can and can't do? Mr. Doak?
Yes, sir. Great question, and very, that you are absolutely right. With the mobile phone devices, the innovation is definitely taking on. One of the things that we just held an innovation summit in Tulsa with in partnership with Oklahoma State University and the University of New Mexico. They presented on a Project Echo, which actually has dramatically helped and assisted rural outcomes across the country. And I think when you take a look at this program, it's in my report. And see what they're doing, the partnerships that they're doing, able to drive great health care through programs to rural America is the innovation is happening at such a quick level that you're absolutely right. I think that's why the NAIC and the leadership under President Ted Nickel from Wisconsin formed the Innovation Committee, that we really have to stay ahead of the curve. So you're on the right track, sir.
Mr. Chairman, could I ask all of the witnesses to provide in writing for the committee thoughts that they might have on offering multi-year access to plans? In other words, individuals in the individual market, not signing up for 1 year, signing up for 5 years or longer, so that we can truly feel the benefits of the investment by the insurer to get people healthy, to keep them healthy, to eliminate the risk tail that drives up these premiums so drastically. Thank you, Mr. Chairman.
Thank you, Senator Burr. That'd be very helpful if you could do that. Senator Hassan.
Well, thank you, Mr. Chairman and Ranking Member Murray, for holding this hearing and the hearings we're going to have. I know I shared, I think what Senator Casey said, people around New Hampshire when I said we were going to have bipartisan hearings and listen to experts who actually deal with the nitty-gritty of how health insurance and health care works. There was a real sigh of relief. So I'm very grateful for the hearings. I'm very grateful for a panel that pronounces insurance in all different ways because I'm the daughter of a Southerner and a New Englander. So you sound like my family to me. And I also think it's really important that you're all here because it is essential that we really drill down to how things actually work as opposed to just talking about big concepts. One of the concerns I have, for instance, when we talk about letting people buy into ERISA or employer-sponsored plans is, well, that sounds great, but most people have their employer subsidize the plan. So remember when we enacted COBRA, so people who terminated their employment could still buy their plan, a lot of people couldn't afford it once the employer subsidy went away. So I think it's really important as we have these discussions that we hear from all of you about how things work. And to that point, Secretary Miller, I'd like to just start with you. Right now, about 5% of people who buy health insurance coverage in the individual market represent almost 60% of healthcare claims costs. So we've talked about reinsurance. We've talked about the importance of what a federal reinsurance plan could have as kind of the biggest bang for the buck idea. I wanted to just ask you a little bit about how the temporary reinsurance program that the ACA had at the beginning of the program, how did it successfully moderate premiums in your state?
Senator, in Pennsylvania, in the last year of the program, we saw between 4 and 7% increase because of the end of the program. So in other words, it moderated premiums by 4 to 7%, and that's what we saw an increase happen between 2016 and 2017 was when that program went away.
Okay, well, thank you. And that brings me to another question, which is for Commissioner Wing-Heier. When you talked about using the 1332 waiver to establish Alaska's reinsurance program, as I understand it, the 1332 waivers program initially wasn't really to help states establish reinsurance. It was to help them innovate within the insurance market in their state in ways that could really help move us forward and gain efficiencies and really tailor the insurance programs to the state. So I guess the question I have is, if we had a federal reinsurance program, could the states then turn to 1332 waivers to do some of the other work that we all need to do and that states need to do to tailor their insurance to their state?
You most certainly could. The flexibility should be great within the waivers. It should be only limited by the innovation that the state can come up with. At the time, Alaska was down to one insurer, as we still are.
Yeah.
And we felt that we were in enough of a crisis mode that we took the appropriate action at the appropriate time. Our legislature agreed to fund for 2 years the reinsurance program, which led us to then apply for the Section 1332 waiver, which will allow us for a 5-year funding mechanism for this. We will certainly be looking at other waivers in the future to benefit our citizens and to make sure that our program is uniquely designed for Alaskans and our conditions.
Yeah, and I applaud you all for doing what you did. I just think if we had the federal reinsurance program like the first one we had as a part of the ACA for the first 2 years, then you all could be doing that second stage of work that you're approaching now. Secretary Miller, I want to come back to another issue. I know that your state is grappling with the opioid addiction crisis, as so many of our states are, and as you may know, New Hampshire has been particularly heavy hit by it. And I know that you've been both an insurance commissioner and now, as I understand it, you're acting Secretary of Health and Human Services. So if the administration decided to cut off the cost-sharing reduction payments, how would that affect access to coverage for people who are suffering from opioid addiction?
Senator, I think Pennsylvania, as all states right now, we're grappling with this issue, and it's having such a huge impact on our communities. And we need to stabilize this market so consumers have options in terms of quality coverage. The essential health benefits and that requirement ensures that people have access to that coverage if they have ACA compliant coverage. So we need to stabilize this market, keep insurers in it. By doing that, we will have more competition. I think the problem right now is that it's not a very attractive market to be in because of all the uncertainty, and that's hurting the competition. That's why this conversation we're having today is so important, because if we can stabilize this market, we can increase the competition, make sure consumers have options that include that quality coverage that has that treatment available for people who are struggling with addiction.
Thank you very much, and thank you, Mr. Chair.
Thank you, Senator Hassan. I'm going to go ahead and ask my 5 minutes of questions now, because I want to ask the whole panel about reinsurance, since all of you've mentioned it. And I have 2 questions, and I'll ask them and then let you just answer them. One is, how can we make it easier for you to use the 1332 waiver to set up a state reinsurance program, as Alaska and Minnesota have done? As I understand it, Ms. Wing-Heier, you're not getting any more federal money than you did before. You're just using it better because you're able to use some of the federal money to pay for 85% of the reinsurance program. State pays for 15%, and your lower premiums 20%, with basically the same amount of federal dollars. Is that basically right?
That's correct. Our innovation waiver was based on the fact that the reinsurance program reduced the liability of the federal government to pay the advanced premium tax
Right.
credits that would have been paid.
Well, then here are my 2 questions. If we need reinsurance, why can't states do it? They're the same taxpayers. I mean, let's take Maine, for example, not a rich state. Maine set up a reinsurance program, $4 per month applied to all policies and insurance plans, plus insurance ceded 90% of the premiums of the risk given to the pool and paid the first $7,500 in claims. The federal government has a $20 trillion debt. The federal government is paying an average, according to the Congressional Budget Office, $4,200 for each individual in the individual market who qualifies for a subsidy. If a reinsurance program is such a good idea, and Alaska was able to set one up using some state funds, and Minnesota was using some state funds, why don't states do it? All it takes is money, and state budgets are balanced. The federal government's $20 trillion in debt, already contributing a lot. All of you could put a $4 tax on every policy, create enough money to take the sickest people out of your individual market and lower premiums for everybody else. So my questions are, why don't you do it, number one? And what can we do to make it easier for you to use Section 1332 to pay for it? And if the answer is, well, our legislature won't approve any more money, that's not a very good answer to those of us in this legislature who have a $20 trillion debt. So who wants to answer that?
The states that I have talked to, they like the concept of the reinsurance waiver and the application, but the requirement for Alaska was that we seeded the program for the first year. And we do hear from states that they cannot get the funds from their legislature for that first year to show that there is an impact to the rates that would bring down the rates so that there is the money in the premium tax credits, that it's a chicken and an egg, that they want to see the results of the premiums coming down, so there is that savings in the premium tax credits to then put the pass-through funding back to the state.
Well, but there's nothing to keep you from raising taxes or putting a charge on every policy in Alaska to help pay for your insurance fund, right?
That's true, but I would tell you that in the state of Alaska, we would have a hard time putting that tax through, strictly because we're such a small market.
Yeah.
We would be taxing the market we're trying to help,
Yeah.
the 18,000 that we're trying to help.
Who else has an answer? Why can't states do it, and what can we do to help you use 1332 to set up your own reinsurance fund, at least initially?
Senator, what you can do is certainly make it an easier process than we have right now, so that when you file for a waiver, that you have a quicker turnaround time, that you get definitive answers on a much shorter notice. You also heard the description here of saving us from having to wait until our legislature's in session before we have to return to them. In the states like Washington and Oklahoma, where we're elected as insurance commissioners, turn it over to the insurance commissioners to make that decision. In the other states, leave it to the governors to make the call. We're not asking to have increase the national debt at the federal level when it comes to 1332. What we're asking for is to make it more predictable as to whether it's going to work or not. And in the end, even though you might wind up having some impact on the federal budget, it's one that's going to have to meet the budget neutrality standard. And I'm in favor of that. I think that's not unreasonable to have that standard apply when it comes to these 1332s. So we're not asking for more money, just make it process work a little bit smoother than what we have right now. It's with some certainty.
Thank you.
Senator
out of
Alexander.
time. Yes, and then we'll stop there.
I agree with my other elected colleague from Washington, is that, let the states make up more of their decision. In Oklahoma, it's going to be at a $2.15 charge for folks in the self-insured market to come up with approximately $325 million, which is going to have the reinsurance program is going to pick up everything from $15,000 to $400,000. It's a fee, it's a tax disguised as a fee, basically, on Oklahomans. But I think that once this is, it's up to Oklahomans to decide how they should put this together and how we should actually come up with that money with a state that's having a very challenging time, as you're probably going to hear from some of the other governors tomorrow. That's kind of where we are in Oklahoma.
Thank you, Mr. Doak. My time's up. Senator Kane.
Thank you, Mr. Chair. And again, to the chair and ranking member, I'm so happy we're here in this set of hearings, hearing from the people who are affected about what's good, what's bad, and what needs to be fixed about our healthcare system. I'd like to make sure everybody knows what you do. You're expert witnesses. You're in the box, and you're giving us some recommendations, and there's some significant consistency between you, whether you work for Democratic or Republican administrations. I am correct that each of you, Ms. Miller, until your recent promotion, each of you are the chief insurance regulator of your state. Is that correct? Are all of you active in the National Association of Insurance Commissioners? And you're the incoming president of that. Is that not right?
That's correct.
The NAIC has a mission statement. Each of you, I know, have different state laws, so there's some peculiarities about your states. But the NAIC says the mission of the NAIC is to assist state insurance regulators, individually and collectively, in serving the public interest and achieving the following fundamental insurance regulatory goals in a responsive, efficient, and cost-effective manner consistent with the wishes of its members. The 5 goals of the NAIC: protect the public interest, promote competitive markets, facilitate the fair and equitable treatment of insurance consumers, promote the reliability, solvency, and financial solidity of insurance institutions, and 5, support and improve state regulation of insurance. Again, recognizing that each of your states have your own legal peculiarities, is that a mission that you generally accept in the work that you do as the chief insurance regulator in your own states? Let me then ask this, and Ms. McPeak, you presage this a little bit in your testimony. All of you support, Mr. Doak, with a qualification that's important, all of you support the CSR payments continuing. You said if we choose not to alter the current structure, that would be necessary. All of you support, to some degree or another, state or federal reinsurance. There are other areas of commonality. None of what you're proposing to us today, though, is because you're trying to bail out insurance companies, correct?
That's correct.
Because I've heard colleagues in this body, the other body, and outsiders say things like CSR payments. That's bailing out insurance companies, or reinsurance. That's bailing out insurance companies. But as the chief insurance regulator in your state, who's pledged to basically follow these goals, you're not here to bail out insurance companies, correct?
That's correct.
Well, let me talk about one of these, reinsurance, because both the CSR and reinsurance things have been talked about as if they're insurance company bailouts. Now, I'm going to use my sort of meathead PowerPoint to see if I understand what reinsurance does. In a health market or any market, because we use reinsurance at the federal level for crop insurance, flood insurance, Medicare Part D, we used it for the Affordable Care Act. But healthcare, families have different costs. Some have low medical claims, some have medium medical claims, some have really high medical claims. If an insurance company has to write a premium to cover all that, they're going to write a premium up here. If you can provide a backstop on the high-cost claims, they don't have to write the premium here. They can write the premium down here. So it generally, reinsurance is a tool that you're all familiar with, that for the low or moderate cost, sort of the normal claimant, has a significant, can have a significant effect in reducing premiums. Isn't that correct? Then when you get to the high claim side, by providing reinsurance, what you're doing is you are providing a backstop. Senator Enzi called it a stop loss, a backstop. And that has the effect of providing people protection. but it also, by providing a backstop, keeps insurers in the market that might otherwise vacate the market. Isn't one of the reasons that many insurers are vacating the individual market is because they are worried about these high-cost claims? Isn't that one of the main reasons they're vacating the market?
Yes, Senator, if I could respond, you're exactly correct. And in addition to that, when you have very limited carriers in a market like the majority of my state, if you are the one carrier riding in that market and you know that you have guaranteed issue, guaranteed renewability, and no ability to capitate risk because of no lifetime maximums, you have to rate everyone high because you're taking all comers and it's guaranteed renewability. And so if you are able to say this is the backstop and this is the ultimate level of risk that you would have for writing in this market, it does entice additional insurers to write in that market because they can better estimate the risk.
And so the backstop ends up having a double benefit. It encourages insurers to stay in the market, but it also allows them to do a premium that doesn't have to take into account all of the super high cost claims, but that premium then is more favorable to the average person. And by reducing premiums on most, because so many folks get the advanced premium tax credits, the subsidies, when you bring the premiums down on most, you also reduce the federal premium payment, which has a countervailing effect. Reinsurance costs something, but it also brings down the federal government's obligation by reducing the advanced premium tax credit. Isn't that correct? And that's what you're using in your state to try to use that reduced federal obligation down the road as one mechanism for paying for what Alaska is doing with its state reinsurance program, correct? Senator Carper and I have a reinsurance bill in that we think would basically go what we did with the first 3 years of the Affordable Care Act and put a reinsurance provision back in that we think would accomplish all of those goals. It would reduce premiums for the overwhelming majority of individuals in the individual market. It would provide a backstop that would keep insurers in. And by reducing premiums, it would also reduce the federal obligation to pay the advanced tax credit, the advanced premium tax credit, which would have a countervailing effect in reducing the cost of a reinsurance program. And I know that may not be the immediate issue on the table, I understand, but I'm happy to hear that to some degree, this is a concept that these witnesses support. Thank you, Mr. Chair.
Thank you, Senator Kane. Next, we have Senator Young, then Senator Murray, then Senator Roberts, and Senator Warren.
Well, I want to thank our panelists for being here today. I think each of you recognize that if we don't control the cost of healthcare delivery in this country, we're going to continue to see an increase in the cost of health insurance, whether that's at the consumer level or among taxpayers or some combination thereof. And a number of you spoke to that in your testimony, and I thank you for bringing that important topic up. And so I'd like to focus a couple of questions on that area for each of you. What do you think the primary drivers of healthcare cost increases are, based on your professional experience, and what are your ideas for actually bending the cost curve down as we head into the future? And I'll start with Ms. McPeak, because I know in your testimony you spoke to the importance of incentivizing preventative care, and perhaps you could fill in some details on that.
Thank you, Senator. Our experience is that our claims costs in Tennessee are extremely high. Those are real dollars going out for real health care services that are being provided. The majority of those seem to be going to prescription drugs and also to comorbidities, real claims and issues that need to be addressed for our population. Now, bending the curve down is certainly something that can be affected through preventative care, wellness initiatives, and certainly an examination of the reimbursement costs to see, is there a discrepancy that is reasonable from area to area in my state, and then also from Tennessee to surrounding states.
What's the best way, to your mind, to incentivize preventative care? And preventative care, that can be quite broad, right? From a gym membership to seeing your primary care physicians, what have you. It's a better wellness program for your life.
We would certainly appreciate the ability to manage those outcomes for Tennesseans, and we'll use some of those programs on our TennCare side that have been pretty effective for disease management, for health coaching, smoking cessation, and then certainly the physical movement and wellness attributable to the fitness activities.
Thank you. I'm going to go down to Mr. Doak because in your testimony, you spoke to the importance of price transparency, empowering the consumer based on the information of services provided and the perceived value of those services. So it is a lack of transparency, to your mind, a primary driver of healthcare costs and thus health insurance premiums? And if so, how do we improve the functioning of the market so there's a more transparent market?
Great question. Thank you, Senator. I think one of the questions, one of the answers is as I mentioned in my earlier discussion, that was very near and dear to former Oklahoma Senator Coburn, is talking about price transparency. We've seen that through and I would ask the committee, as we said earlier this morning, to possibly invite the CEO of Oklahoma Surgical Center to testify on behalf of what he's been able to do with transparency in Oklahoma City and where some of those things are going. I think the more transparent we can be with our cost all through healthcare is that you're going to provide and empower consumers to be able to see the outcomes that Senator Burr was talking about relative to the cost expenditures. And there's various places around the state of Oklahoma that are doing that very well. So I think that's a true opportunity.
But you don't have particular recommendations here at the federal level regarding obstacles we could remove or regulations we could put in place so that it would facilitate more transparency?
Well, I think that's something worthwhile to consider. I'm always a bit hesitant to have anything further done here in Washington. I'd rather see it done at the local and state level, quite frankly.
Oftentimes a healthy instinct from my perspective. I'm going to give others an opportunity to speak to this issue.
Senator, I'd certainly put a high emphasis on pharmaceutical drugs. That is the one area where if you remove the shackles that are on the states right now as to what they wind up doing on contracting, either through their Medicaid program or other programs that they have at the state level, we can have a very strong impact, particularly if we join together with like-minded states to take on that same approach toward bargaining when it comes to these drugs. That is the #1 driver in the individual market. We see it with our filings, is on the cost of pharmaceuticals.
I'm pretty much out of time here, so I will give others an opportunity to respond to that question in writing. I would just say on pharmaceutical costs, we want to make sure that we don't absorb an opportunity cost of future research and development, life saved and improved into the future by adopting some of the suggestions you put forward. Thank you.
Thank you, Senator Young. Senator Murray.
Well, thank you very much, and this has been really great. A lot of senators are participating, and I think they all really appreciate all of your testimony, so thank you for being here. Commissioner Kreidler, I wanted to ask you, in your testimony you talked about the cost-sharing reductions are the difference between whether a 40-year-old in Tacoma earning $23,000 per year has a $2,000 deductible or a $7,000 deductible. Consumers have really come, I think, to rely on these measures to lower their own health care costs, the same way that employer contributions to help keep costs down for people who get insurance through their jobs. Something changed this year. President Trump has made patients and families and insurance companies and state regulators play this guessing game about whether or not those payments are actually going to be made. And we know that failing to make those payments is going to spike premiums for the most popular plans in the marketplace by 20%, leading an increase to the federal deficit of $200 billion. So this is really an important issue. And I wanted to ask you, what did you have to change about the way you review and approve insurance premiums this year because of that guessing game?
Senator, it's one where we have to sit down with the health insurers and really press them on it. But the point has been made that if you get down to just one carrier in a particular county, you don't have a lot of bargaining flexibility. They're in a position of saying, well, if you don't give me the rate increases I want, then we're looking toward the highway, and then you don't have an insurer there. So we're under a lot of pressure. stabilizing the market is number one. You got to stabilize that market, and the CSRs are number one from the standpoint of what you can do immediately. You can have a direct impact, get away from this idea of funding on a month-by-month basis or even a year-to-year basis. It's really got to be multi-year with some real predictability in the market.
So my additional question to you is, we've heard 1 year, 2 years. Tell me what the difference between, if we just did a 1 year, what a difference that would make rather than a 2 year.
Well, clearly, 1 year is a whole lot better than month to month. But even 2 years is very tough because of the range of which the insurers are planning right now as to what their rate increases are. But I mean, any degree of increase in predictability that goes beyond this situation we have right now of being so tentative right now with just month to month is going to help. The longer we can give it, the better it will be.
The more certainty, the lower the cost. Is that
absolutely, absolutely.
All right. I wanted to ask you, Commissioner Wing-Heier, because I noticed when Senator Baldwin asked about the navigators and the money there that I think you testified that it's really needed in many remote parts of Alaska, used across the country in really important ways. The budget for navigators has been cut by 40%. Tell me what impact that is going to have on you in Alaska.
We are very concerned it will have a major impact in our enrollment. I know that Commissioner Doak testified that he does have insurance brokers and consultants throughout much of his state. We don't. In most of Alaska, outside Fairbanks, Anchorage, Juneau, and other cities, there's not an insurance broker or a consultant to be found. We rely on the clinics and the navigator programs to explain benefits and enrollment to the people living in rural Alaska. This will be devastating to our population to know what their options are, to understand basic things from the dates of enrollment. There's also a part that is very cultural in Alaska in the fact that we have a variety of languages, and the navigators cross that bridge in being able to talk the Inupiaq language or the native languages of Alaska and Tagalog, other languages. They provide that service. We don't have that very readily in the insurance community, unfortunately.
All right. And Commissioner Kreidler, quickly, our state's looking at a 1332 waiver. When applying for that kind of waiver, states have to show that they are going to cover the same number of people, the same types of services, and the same amount of out-of-pocket costs for consumers. Those are the guardrails in the waiver. Can you just talk really quickly about how important those guardrails are as you look at the waiver?
Senator, we've changed the environment that we have right now with health care delivery through insurance because of the ACA. We're now competing on quality and service because we have the standardized benefits, the essential health benefits, limitations on out-of-pocket expenses. So it's changed the dynamic of the game tremendously. So if we want to go forward and have the insurers in there, we've got participating. It's absolutely critical that we wind up making sure that those guardrails aren't eroded away, but focus on what can really make a difference. One, stabilize, and then second, be in a position to allow the insurance companies to innovate without being punished with a reinsurance program to back them up.
Okay. And Mr. Chairman, I do want to submit 4 letters for the record. They're actually signed by hundreds of leading patients, disease, physician, provider, insurance, and business organizations that are requesting multiple years of certainty for out-of-pocket reductions and federal investment in risk mitigation programs like reinsurance we've heard so much about, and preserving the protections for pre-existing conditions, including the essential health benefits, and I would like to put them in the record for today.
Thank you. They will be. Thank you, Senator Murray. Senator Roberts.
Yes, thank you, Mr. Chairman, and thank you to all the witnesses for taking time out of your very, very valuable time out of your schedule to come and visit with us. As rates are filled and not filled by some plans, obviously exiting the marketplace like we've seen in Kansas City in action serves absolutely nobody. So thank you for holding this hearing. I think it's important we focus on permanent or longer-term reforms so we can
make to help slow the growth of premiums and maintain or increase insurance options for consumers as opposed to simply patching or providing an influx of cash to these markets, which has been touched on by the witnesses. I know many are focused on the uncertainty surrounding the cost-sharing reduction subsidies, but I think it's important to note that at least in Kansas, we've had insurers leaving the exchange market before this administration or the court ruling on this matter, and with the CSRs in place, premiums still doubled in Kansas since Obamacare has been in place. And I think that's only one piece to the puzzle with regards to ESRs. Tighter age rating bands can be an answer. I know that's controversial. The health insurance or HIT tax, that's just a tax that's passed on to the consumer or the patient. Other mandates that you've talked about all add to the premium increases. We had 60,000 families paying $13 million in penalties in 2014. $6 billion, I think, was the figure with regards to the nation as a whole. So as premiums continue to increase, we had something in the recent reform proposals that didn't pass, obviously, considered by the House and Senate. They took two different approaches to encourage, not mandate, folks to maintain continuous coverage. From your position as insurance commissioners, which do you see as more effective, as well as which would be easier to operationalize, a penalty on premiums for lack of continuous coverage, or a waiting period for enrollees upon returning to enroll in coverage, or anything else you might suggest? We'll start with Mrs. McPeak.
Thank you. I have a preference for the waiting period over the premium penalty for not maintaining continuous coverage, because there is an administrative issue for our insurers that have been participating in the exchange market with individuals coming in and out of coverage, and really trying to catch up with premium payments through grace periods. And so I think, from my perspective, a waiting period would be more effective to incentivize consumers to maintain continuous coverage.
Appreciate it. Sir?
Thank you, Senator. I think one of the things that's really been challenging for the states is not all states have truly embraced the Affordable Care Act. The expansion of the Medicaid program had a very profound positive impact. Creation of our own exchange, so we were more in control of our own destiny. Establishing network adequacy standards that reflected our values in the state of Washington is something that we did. Most states did not take those actions, and as a consequence, they've seen more in the way of rate increases. Our rate increases have not gone up until this last year. We were under 10% per year, and now we've seen a marked increase. Stabilizing the market is going to be the thing that's really going to make a difference from our standpoint.
I appreciate that. Next, please.
It's a tough call, because you hate to see anyone be without insurance. But we have the special enrollment periods for a reason, and that in itself brings into your waiting period, because you cannot just, in all circumstances, just go and enroll if you miss open enrollment. There's very few criteria that allows you to enroll if you miss open enrollment. So Alaska would probably be looking more at the penalty.
Yes, ma'am.
You know, I think we all want to do everything we can to make sure our risk pools are as robust as possible. I haven't seen an alternative to the individual mandate that would be as good an option to make sure that we've got the young and healthy. And I'm not saying the mandate has been perfect by any stretch, but I haven't seen an alternative that would do as well as that in terms of keeping the young and healthy in.
Oklahoma?
I am not in favor of a mandate. You might be surprised, but I think that there are other ways to reach, plan design to reach this group that does not have insurance, avail themselves of more creative plan design relative to catastrophic plans for the young invincible, to move them into possibly using health savings accounts, as Director Heier mentioned. But I think there are ways, and I'm not sold on this marketing campaign that some of these, that a few of the senators talked about either. Insurance companies have been marketing at every football game we watch. Possibly if they incentivized agents and brokers to sell this type of product, they might have a better result than use navigators.
Is that football game when Oklahoma comes to Kansas State?
Yes, sir.
I appreciate that. I have a real quick question. I'm out of time, and I apologize for this. How would increasing the age rating curve to 5 to 1, or maybe 4 to 1, as opposed to 3 to 1. That would be an intermediate change, if you so choose, with regards to be an answer on the individual, or trying to get more younger people into the plan. Are you for it, against it, what? Yes or no? We can start with Oklahoma rundown real quick.
Well, we're basically out of time, so if you could be quick about it, then submit your...
Well, they could submit it for the record, Mr. Chairman. I appreciate that. Thank you.
You can make a short answer, that's okay.
What was the question, sir?
The question is on the rating ban. The exchange market doesn't have enough of the young,
Correct,
the
yes.
oldies.
I'd be in favor of changes.
I would have some concerns about increasing the rating band.
We have concerns with increasing the rating band strictly because our rates for the older population, the 3, are so high right now, we'd price them out of ever being able to afford it.
We say more mature in the Senate, but go ahead.
Washington likes 3 to 1. We'd have in statute 3.75 to 1 currently before the ACA, so we weren't far off of 3 to 1 to even begin with.
I would be in favor of expansion to 5 to 1 to bring the younger, healthier into the risk pool with more affordable premiums.
Thank you.
Thank you, Senator Roberts. Senator Warren.
Thank you, Mr. Chairman, and thank you, Mr. Chairman, for holding this hearing. Thank you, Ranking Member. I think it's important that we're having a bipartisan conversation about how to improve health care instead of destroy health care in America. But at the same time that we're having this conversation, President Trump is actively working to sabotage our health care system. He's using a lot of different tactics, but 2 of them include reducing federal help to keep out-of-pocket costs low and cutting 90% of the advertising efforts so that people know about affordable health insurance. So we've talked some about this, so let me just see if I can do this first part quickly. I just want to ask about the first one, withholding the federal dollars that keep costs lower. Commissioner McPeak, are American families better off or worse off if the president refuses to make cost reduction payments?
If those payments are not funded, the American consumer is worse off, certainly. Not only the individuals that are eligible for those reduced co-payments and deductible amounts, but the individuals that would have to pay the increased premium dollars from the carriers associated with that lack of funding.
Okay. And Commissioner Kreidler, if the government cuts advertising, fewer people will sign up for health insurance, but how does that affect the costs for the people who do sign up for health insurance?
You want to encourage the people that are probably the least likely to sign up because they're more likely to be healthier individuals that are now protected. They don't become the free riders in our system that rely on uncompensated care to take care of them. Inadequate as that might be, it adds cost to the system. The more accountable you make health care, the better it is for all of us.
Well, very strong points on both of these. You know, the president has been perfectly clear about what he's doing, sabotaging health care and driving up costs for families. It's petty, and it's going to hurt millions of people. And if he won't stop on his own, then Congress should stop him. But for me, that's just the beginning of what we need to do to really improve health insurance in this country. Secretary Miller, did the ACA put in place any sort of restrictions on how high an insurance company can raise its premiums in a given year?
Senator, I think aside from the fact that in many states we approve those rates.
I'm going to ask you about the states.
There are no restrictions in the ACA.
That's right. The ACA makes no restrictions at all, right? But some states impose tough rules to protect consumers, and they insist that the insurance companies have their rates approved by the insurance commissioner before those rates can go into effect. So let me ask, Secretary Miller, in the past years, before all the chaos that has come to the markets lately, did you let insurers in Pennsylvania charge whatever they wanted for their plans?
I did not, Senator.
You did not. Commissioner Kreidler, I understand that in Washington State, like Pennsylvania, insurance companies have to get permission ahead of time. Do insurers always come up with reasonable premiums the first time around?
No, they do not.
Someone
And,
laughed out loud during that. Go ahead.
we apply a very vigorous review. In fact, we're among those states that are the most vigorous. In fact, we're recognized by the federal government as being a state that can do that hard review. I think several of us are in that position.
Hard review, and I think you have some data on how much you pushed down one of the most recent premium requests.
We do, and I'm not going to, I can't remember exactly which one that was, but
Maybe a 30% drop in average rates?
it was something like that. Yes.
All right, good, good. I should say it the other way. Yeah, 30% drop in average rates. You know, the reason I raise this is because letting insurance companies charge whatever they want opens up price gouging. Rate review programs among the various states have saved consumers about $1.5 billion in premium costs in just 2015 alone, in a single year. Unfortunately, not every state is stepping up on this, and the difference is huge. From 2010 to 2013, just that short time period, premium increases in states with the weakest review programs were 10% higher than in states with the strongest review programs. And that's a lot of money that a lot of families paid out. And for me, it just shows the kind of work that we need to do. Right now, Medicare restricts premium increases for most beneficiaries, but the ACA doesn't. Medicare has high standards for the Medicare Advantage plans, while the ACA in many cases has lower standards. Medicare and Medicaid plans cover everybody who qualifies. ACA plans can pick and choose who they get in the game with. Let's be blunt. We can either make these markets work better for consumers, or we can let insurance companies hold people hostage in order to maximize their own profits. So in my view, if we're really serious about trying to make these markets work, we need to talk about the kind of rules that make them work best for consumers. Thank you, Mr. Chairman.
Thank you, Senator Warren. Senator Whitehouse.
Thank you, Chairman. Let me first, as a former insurance commissioner in my state, welcome our distinguished panel. And again, thank the chairman and the ranking member for trusting this committee to do a fair and thoughtful bipartisan process. We did it in education with great success to a unanimous, significant bill out of this committee, and I'm confident that we can do something very worthwhile here. I want to open by pointing out that our health insurance commissioner in Rhode Island has written that the ACA has worked in Rhode Island and we have a remarkable story to tell. I'm quoting a letter from this January. Rhode Island has enjoyed market stability and has avoided dramatic increases in premiums seen in other states. Over the last 3 years, premium increases in the individual and small group markets have been relatively modest. For plan year 2017, average premium changes in the individual market will range from a 5.9% decrease to a 5.9% increase based on issuer. In the small group market, average premium changes in 2017 will range from a decrease of 3.1% to an increase of 3.6% based on issuer. So, to my colleagues, please follow the Hippocratic Oath and do no harm to those of us who have states where this is all working very well. The last point I'll make before I go to questions is that I hope that the bipartisan process that we're embarked on here with respect to shoring up the markets can continue and be extended into other areas. Patient safety and medical errors remains a huge issue with tens of thousands of American casualties every year. There's nothing Republican or Democrat about ending hospital-acquired infections. The wild variations in care and outcomes is an issue that we can address. It ought to be bipartisan to find the best states and the best practices and encourage those. There is nothing Republican or Democrat about high administrative overhead and continuing feuding between insurers and providers over payment. The care that patients want at the end of life ought to be something we can make sure that they actually get. There ought to be no partisan difference about honoring a patient's and a family's wishes as they near the end of life. And finally, payment reform so that doctors are compensated for keeping people healthy rather than starved on that front and compensated only when they do late-stage procedures once somebody's health is already compromised, another great area for bipartisan action. So I hope that we will continue on those fronts. My questions are primarily going to be to Director Wing-Heier. I appreciate you coming all the way from Alaska. That's pretty impressive. And I want to ask you about the 1332 waiver process through which you created your reinsurance program. You created it not based on hitting a financial number, a dollar number in claims, and then having the reinsurance kick in. You created it based on the diagnosis, based on conditions, correct?
Yes, sir, we did.
And why did you make that choice, and how did you choose the conditions?
We did what we call a data call and had all the insurers that were in the market the first 2 years submit their claims. We submitted that data to an independent actuary, who then we had segregate the claims from the highest to the lowest based on the conditions, so we could see what we were dealing with, what was causing the market for our rate increases to be roughly 40% for 2 years in a row. We then made the determination that if we removed the top 10, the top 20, the top 30, we could put a correlation to how that would impact the market as far as how our rates would stabilize or hopefully decrease. In 2000,
was that, why pick conditions rather than, say, stop loss at $100,000 per claim or some other more numerical trigger?
We're looking at the biggest impact we could have to stabilize a market that was losing we were down to one insurer. We needed to stabilize the market to the greatest extent we could. And removing the entire claim or the entire person from a very small pool had the biggest impact or the biggest bang for our buck on our rates.
What happens year to year as somebody goes into a new enrollment period or perhaps shifts their carrier? Does the new carrier know that your reinsurance for that individual, because they have the requisite diagnosis, will follow them, or do they have to stay with their, how does it work in terms of future enrollments?
If we had a second carrier, based on the condition, that person would be seated the first of every year or the first time they treated, and we're continuing the diagnosis, be it a chronic condition or a new condition.
So the reimbursement, the reinsurance for the carrier follows the individual year to year for as long as the diagnosis or condition remains in place, correct?
As long as they're treating.
Did you consider setting up a risk pool rather than a reimbursement system for those individuals?
Yes, we did.
And why did you choose the reimbursement system rather than the risk pool?
We chose the reimbursement system, again, to have the biggest impact on a very small market, 20,000 people. 20,000 people, we had
So the administrative problem of setting up a separate risk pool would have been a problem for a small
we
number
feel
of
that we had a
patients like that?
pool to begin with, and it, as with the 20,000 that were in at the time, was not succeeding. So to create a pool within a pool, we needed to get those high-cost claimants out of the pool so that the entire individual market, we could reduce the rates, and people could afford the premiums.
Got it. My time is running out here, but I would like to ask a question to each of you. This will be a question for the record, given the timing. But if an insurance company came to you, to your organization, proposing to sell health insurance in your state, I'd like to know what steps, such particularly as setting up a provider network, you would expect or require of that insurer. And conversely, to turn the question on the other side, what concerns would you have about an insurer showing up in your state purporting to offer health insurance who was not prepared to create a provider network and go through whatever other steps you would require? So with that, I'm out, but I'd be really interested in your answer to those questions. Thank you.
Very good question. Thank you, Senator Whitehouse. It's been a very good discussion, both the hour before we started and this. I want to ask Senator Murray if she has concluding remarks. Senator Franken, do you have some concluding remarks?
Well, I was going to ask a question about prescription drugs, but I see you want to conclude, and I respect that.
No, go ahead if you'd like.
Well, and I just wanted to ask kind of a rhetorical question about the cuts by HHS in advertising for the exchanges. Mr. Doak said that insurance companies advertise at every football game that we watch. Are those insurance companies just stupid, or maybe insurance advertising works? That's the rhetorical question. I think there's a reason those insurance companies advertise, and I think that the
I guess the question is, are they funded by the federal government? Does that make sense or not?
I think the issue is does advertising work? And if you're cutting it by 90%, you're probably cutting the effectiveness of the advertising, whoever pays for it.
But we have thousands and millions of licensed agents and brokers all across the United States, Senator, that have been doing a great job in the health insurance market before Obamacare and could be doing the same after.
I really meant it as a rhetorical question because, which I said, but good luck with that is right. The point is that they advertise for a reason, whether or not they sell it through brokers or not. Advertising does work, and that's why they advertise. And I had a question on pharmaceuticals, but I really don't want to eat up time. Although I would like to thank the chairman. We had a hearing on pharmaceuticals, and I think as you all have said in one way or another, that pharmaceutical spikes in the last 3 years or so has been one of the things responsible for the premiums going up. And I would love to hear your thoughts on how we can get those under control, and maybe we can do that in a written answer so that the chairman can and the ranking member can conclude. One other just thing, my favorite moment in the hearing so far was Senator Whitehouse thanking Ms. Wing-Heier for the hardship of coming from Alaska. My favorite moment was seeing Senator Murkowski's expression when he did that.
Thank you, Senator Franken. Senator Murray, do you have any concluding remarks?
You're easily entertained, Mr. Frank. I want to thank all of our witnesses today. This has been an extremely important first step. I know we have 3 more hearings. We do have a very short time frame within which to do this, and we need to seize this opportunity. And Mr. Chairman, I know my side looks forward to working with you, and I appreciate the opportunity today.
Thanks, Senator Murray, and I thank the witnesses, too. You've been very patient. You've given us a lot of time. The senators, I thank the senators. I mean, we've had maybe half the Senate involved this morning in this discussion. That's pretty unusual, and mostly on our best behavior. That's pretty unusual, too, so we welcome that. I'd like to conclude with these remarks. One, just these facts from CMS on the Navigator program. I'm not sure what the right amount of money is for the Navigator program. But according to CMS, in 2016, Navigators received $62 million of federal money to enroll 81,000 people, less than 1% of the total enrollees. 17 Navigators enrolled less than 100 people each at an average cost of nearly $5,000 per enrollee. The top 10 most costly Navigators spent a total of $2.7 million to enroll 314 people in the Affordable Care Act. One grantee received $200,000 and enrolled 1 person. Only 22% of all Navigators achieved their own performance goals, so maybe it's an area that needs some oversight. Let me go to a point that several senators have made, including Senator Franken, several others. And I've been thinking this, especially for 7 years, we've been stuck in this partisan stalemate on health insurance, with most of the argument, not all of it, but most of it, about 6% of Americans who buy their insurance on the individual market, when we really should have been spending more time on the fundamental problems with the American healthcare system that have caused it to grow from consuming 9% of the gross domestic product in 1980, about 40 years ago, to nearly 18% in 2015 and a predicted 20% in 2025. At the same time, as was mentioned, we have this phenomenon of 5% of those who receive health care consume 60% of the costs. So we should be doing more on the larger question about addressing health care costs. There's no question about that. Looking at what we pay to visit the doctor, how to get a test at the hospital, that's the transparency Mr. Doak talked about. What we spend on prescription drugs, several of you talked about that. How much excessive paperwork and administrative burdens increase our cost. What more can be done to encourage wellness? I mean, that's really the low-hanging fruit in the whole issue of health costs. What can be done to prevent more serious illness and disease and the high costs that come from being ill? We should be looking at the real ways to bring down the cost of health care, which is the best way to reduce the cost of health insurance. Now, what I've heard today, just to summarize, has been very helpful. This has been a focused hearing on a narrow part of the market where we have most of the problems, 6% of the people with insurance. And what we asked you to do was to focus on what could we do, especially this month, that might affect 2018. I heard three things mostly: reinsurance, cost-sharing reductions, and more flexibility from 1332. Reinsurance, one way to do reinsurance, of course, is the way Minnesota and Alaska did it, which is to use some of the federal money you're already getting to do that. I'm not suggesting that's the long-term solution. Senator Kaine has proposed a long-term solution. Reinsurance has broad support among Republicans, I know. It's not a very complicated idea. It's just take this very narrow market, which is an odd market, small market, and recognize that some people are very sick and we need to create a fund to pay for the costs of some of those people in order to lower the premiums for everybody else. That's what we're talking about. There's a variety of ways to do that: federal tax dollars, state tax dollars. You can do what Maine did, charge everybody something on their premium. There are various ways to do that, but clearly reinsurance is one part of the solution to a long-term fix for the individual market. Now, for the short term, for something we might sit down in 10 days and say, okay, we can agree on this much and try to ask the House and the Senate and the President all to do it in time to have an effect on 2018, maybe what I've heard is adjust 1330 in any way that makes it easier for you to create your own short-term reinsurance next year. That may be hard. Several suggestions for improving 1332 that oughtn't to be too controversial. I mean, the 6-month waiting period. No one mentioned the sort of Me Too application. That is, if Washington puts something in that's approved, why can't Tennessee come right along behind it and say, we want to do what Washington did with one change? That ought to speed things up. The idea of letting the process go ahead with just the application of the governor, or you've suggested the insurance commissioner, and not wait for the legislature to have to pass a law, since some states' legislatures only meet every 2 years. Alaska's submitted a list of reforms that we'll take a look at. I thank you for mentioning those. Planning funds, Ms. Miller mentioned that. That would seem an odd thing to have to do for a bankrupt federal government, to give money to a balanced budget state government for planning funds, but I understand the problem of quick providing of funds so that you can make your application for a longer-term plan. And then I was intrigued with the suggestion, I've heard it often, of what can we do about the budget neutrality requirement and make sure that that doesn't keep you from doing what you would do to make a long-term plan. And is there any way to include the savings that you have in Medicaid with what you're doing in the individual market? The two different waivers that the federal government has. I know that New Hampshire has tried to do some things in that area, and even though the Democratic governors and the Republican governors both support it, they're not able to do it according to both the Obama and Trump administrations. So that's a short list of some things that might make some real difference in the 23 states that have actually started the process for applying for a 1332 waiver. So I'm hopeful that maybe some combination of continuing cost sharing for a period of time, and we can discuss what that time is, and significant changes in flexibility for states, probably mostly through amendments to Section 1332, since it's already in the Act, might provide a basis for action we could take this month. And then if we act, well, then we'll count on the House of Representatives and the President to take advantage of that, and my hope is that they would. That wouldn't end the process. That would only be step one, and then we'd go pretty quickly to step two on a long-term, strong, vibrant individual market, other changes that need to be made in the Affordable Care Act, and I hope we can begin to spend most of our time on the larger issue of health care costs. So if you have other comments that you'd like to give to us, we'd like to have them in writing pretty quickly because we're moving pretty quickly. The record will be open for 10 days for comments and questions. Tomorrow, our committee will meet again to hear from 5 governors to further discuss marketplace stability and how to advance many of the topics mentioned today. We have 2 more hearings next week. Then we'll see where we are and see what we think we can accomplish. Thank you for being here. The committee will stand adjourned.